Ankita Chattopadhyay, Dr. Parag Nigam, Dr. Subir Majumdar, and also the symposium speakers, Dr. Baljet Singh, Dr. Manju Rahi, Dr. Dinkar Raj, Dr. Volker Gertz. Thank you so much for joining. We are having the inauguration, as I said, as well as a mini symposium on One Health. I don't think One Health needs an introduction. It's just what we used to do when we were kids, where the physicians used to take everything into consideration while diagnosing rather than going into super specialties. So we need to go back to those basics, I guess. So once again, I welcome everyone for this inauguration as well as the mini symposium. And I lead into the introduction from Dr. Subir Majumdar, please.
Yeah, good afternoon and good morning for our foreign dignitaries. I will straightforward start. So WHO has listed 13 major threats to the world health-related issues. Of that, infectious disease control, epidemic preparedness, access to treatments, and threat from microbial resistance are very relevant to practice of One Health. Attending human, animals, environment, climate, and soil health issues under a single umbrella is the key for succeeding in our efforts to attain a better global health, which can be termed as One Health. One Health is a collaborative, multi-sectorial, and transdisciplinary approach working at local, regional, national, and global levels with the goal of achieving optimal health outcomes, ensuring interconnection between people, animals, plants, and their shared environment. We are grateful to the vision of Dr. Renu Swarup, our Secretary Madam, who initiated at DBT meetings of strategic planning groups involving very senior experts to suggest what is needed for the country post-COVID-19, and parallelly asked us to create a consortium taking as many specialist institutions in one fold as is possible. After 1.5 years of efforts and 4 or 5 rounds of expert committee meetings, we succeeded in putting up a program and create a consortium of 27 centers, including big medical colleges, AIIMS Delhi, AIIMS Jodhpur, MGR University, Gandhi Medical College, Nazareth Hospital in Northeast, and some centers of medical sciences and veterinary universities across the nation. All partners of which are attending this program today, where Madam has agreed to launch the One Health program and also inaugurate the International Mini Symposium on One Health. Dr. Baljet Singh, Dr. Volker, Dr. Dinkar Raj, Dr. Manju Rahi ji, Dr. Parag Nigam, Dr. Deepanita Chaudhary, they will be speaking on this occasion. In addition, our mentors for this program and many dignitaries have joined. My sincere thanks and regards to them. With this, I will invite Madam to launch the first One Health program of DBT and kindly inaugurate this international mini symposium. Madam, please.
Thank you very much, Subir, and good morning and good evening to everyone. Dr. Hegde, Dr. Subir Majumdar, all those who are present here. There are so many. In fact, when we come on these virtual platforms, it's very difficult to see everybody who's here, all the key speakers today. But most importantly, all those who have come together to really bring this consortium to where it is today. I think my compliments to all of you. And it's with great pleasure today that we are formally launching or announcing the One Health Consortium and also the mini symposium, which Subir just called. I don't know what Subir meant by a mini symposium, because the symposium himself has all the best speakers around, so it can't be mini in any way.
Madam, actually, these are two. Today there will be 4 speakers.
Excellent.
And on 20 and 21st there will be around 20 speakers.
Excellent. So that's the starter. That's the starter or the appetizer to the main meal course which is going to come. So you're actually sort of attracting the best people. No, but I think compliments to all of you. The whole area of AMR, One Health, I mean, this is not new to a fraternity like yours, which is all collected here. We've been talking about AMR, we've been talking about One Health for many years, and the DBT itself, along with many stakeholders, many departments within the government, the ICMR, the Health Ministry, the Department of Animal Husbandry, Ministry of Environment, Department of Science and Technology, CSIR, we've all been working closely together to try and see how we could bring this whole concept to the forefront. Today, if we are in a position to launch a consortium, it's because of that very deep foundation which has been set for so many years to be able to build upon it and then come forward and say all players come together to be able to address this national and global challenge which is before us. The only difference is that today, at the times of the pandemic, it has really come to the forefront. Everyone's realized that One Health is an issue which needs to be addressed. But this is something, in fact, DBT had a couple of years back also organized a meeting, a symposium, a conference along with the FAO, the OIE and others to again bring in, and there were some international partners like the BMGF and others to identify what really are the gaps and what is the roadmap forward. And one of the key aspects that came out of that recommendation, I'm very happy to see Dr. Rawat here, the former advisor from DBT, who's now closely associated with this whole AMR consortium, working with Dr. Subir Majumdar and the current DBT officers. We had been able to put together this roadmap. As I said, a regional expert advisory group was constituted. We had people like Dr. R.S. Paroda, Dr. Padmanabhan, and Dr. Katoch, many people, senior people from ICMR, from animal husbandry. They all came together to discuss exactly this, what is our roadmap? And the key verticals that we were looking at, from surveillance to diagnostics to treatment. And of course, now when we talk about surveillance, we are very clear that it has to be molecular surveillance combined with the epidemiological surveillance. And we've seen that for the SARS-CoV, that how that has given us a very good tool to move ahead. Within DBT, as I said, there have been a number of activities that we've supported, from major center that we supported in the Northeast to programs that the NIAB at Hyderabad has been doing along in partnership, of course, with ICR institutes, with the Animal Husbandry Institute. So we have major networks that were supported, whether it's the bovine tuberculosis network or whether the activities they've been doing on brucellosis and many others, similar activities. AMR itself is a huge vertical for us to move forward. So I'm very pleased that with all the effort which Dr. Majumdar mentioned, they could actually connect with 27 centers. I mean, the consortium launch, which we are doing today with so much of pleasure and pride, has a lot of work that's gone behind it. Bringing together 27 institutes, agencies with a common goal, with a common agenda, it's not an easy task. So, but what I would like to urge you is that now that you all have made all this effort to come together, please work in this consortium mode together, bringing all stakeholders with you to be able to deliver the results that we are looking at in terms of new technologies, new products, new surveillance tools, and also creating a framework which helps us to then look at any of these One Health issues. We have, in fact, groups which already exist, as I said. This consortium should not duplicate what is already being done. This consortium should be the next way forward, because most of you who have become members of this consortium are already doing excellent work in the national programs and also in the bilateral programs. We have a large number of bilateral programs, whether it's with the UK, whether it's with EU countries, whether with some of our neighboring countries, they're all working towards it. So whether it's plant, animal, human, environment, I mean, it's cutting across all these areas. So it's important that you come together and add a value to it. It's also very important because India also plays a very important leadership position for this part of the world. We also have to look at the transboundary movements. And there, it's not just putting in place a surveillance mechanism, but it's working with neighboring countries to build capacities. So one clear vertical within the consortium is building capacities, both in terms of human resource, both in terms of infrastructure, and access and adoption of new technologies. And I think that is where this consortium should also look at working not just within the country to set up teams, but also looking at setting up this regional framework. With WHO, we've had some excellent discussions on this. They've been very forthcoming, and they are agreeing to work with us to set up such a regional framework. For the SARS-CoV genome sequencing work also, we are proposing a similar sort of a consortium. So I think it will be very useful if Subir, you along with all the consortium members have focused discussions on this to see how you can take it ahead. It's also, and in fact, I was looking into the agenda and I've had earlier discussions with Dr. Dipanvita. It's very interesting to see how the startup group, that component of our stakeholders has come forward to partner with us in this very important aspect. Normally, you would say, okay, startups only come where there is a commercial market. This is really a need, which is a national and a global need. But it's important to bring them into the center stage. And for this, I think what is being proposed and talked about as an AMR or a One Health incubator is something which is wonderful. I know Dr. Dipanvita has been in discussions with many teams. We have some of our other incubators like at CCamp and other places, which again could be networked and brought together. But this is clearly one stakeholder group which must come in. So I think for this AMR consortium, for this One Health consortium, Subir, as the coordinator, I think it's important for you to see that you have the academia, you have the startups, and you have the industry. Because unless and until you bring all of them together, the products and the outcomes that you see coming out of this consortium is not going to move through the translation so quickly. But at the end, while I close, I would only like to say one thing. We've been working on One Health for many years, as I said. We've got enough expertise. Now with the COVID, we've had enough learning as well. A lot of the gaps which existed in our ecosystem have been plugged, or we are in the process of plugging them. Remember one thing, we do not have the luxury of time. We do not have to wait for another pandemic to strike before we respond in urgency. This is the time for you to take it forward, because One Health is today our biggest challenge. And let us look at it in the same sense of urgency as we've tackled all the challenges that came to us for the pandemic, because then we would have been able to bring in solutions before the problem overtakes all of us. So I think good opportunity for you. Good luck to each of you. You have the best people together. Let this consortium become an example globally. And I'm sure you will then be able to connect globally with many other such consortiums. So good luck to all of you. As always, it's a pleasure to be here, and I wish you all the best for your future. Thank you so much.
Thank you, madam. If you remember, we inaugurated the guest house on Ganesh Chaturthi, and today is Durga Ashtami. So gathering all instruments to work on One Health against the several kinds of pandemic, I wish that this will be a very good moment to start this program. It just occurred to me. It's a very good day. And thank you very much, madam. With this, I pass it on to Dr. Hegde.
Thank you very much, madam, for the really good words and for inaugurating this. Now I request Dr. Dipanvita Chattopadhyay to say a few words about how they can come as stakeholders in taking this forward, maybe along with us right now, or maybe in the immediate future. Dr. Chattopadhyay, please.
Thank you, Dr. Hegde. A very good evening and morning to all. I thank Dr. Renu Swarup, Dr. Subir Majumdar, and Dr. Nagendra Hegde for inviting IKP Knowledge Park to be part of this very important grand challenge. Madam just mentioned grand challenge. It is a grand challenge. IKP is a science park and incubator in Genome Valley, Hyderabad. We've been working for the last 20 plus years, supporting innovators, startups, MSMEs, as well as large companies to bring their technologies and products to the market. We help by offering laboratories, mentorship, hand-holding, fundraising, go-to-market strategy, and so on. We have a large number of innovative startups, as Madam mentioned, across India working on public health. And I'm expecting all these startups with us would come to the fore to be part of this grand challenge exercise. On the other hand, we also have a very large part of biological is research center at IKP. Bharat Biotech is our neighbor, and United States Pharmacopoeia India is located at IKP. So we have on one hand startups and on the other hand large companies. That is what we bring to the fore. And we are honored and delighted to be part of this consortium. IKP looks forward to collaborating with each one of you, with all of you, and taking your technologies, your ideas to the beneficiaries for the greater good of India and the world. Thank you.
Thank you, Dr. Chattopadhyay. And now we have a special guest among us. Usually when we talk about One Health, we talk about humans, animals, and the environment. Of course, the environment has usually lagged behind. But even among animals, usually we don't talk about wildlife. So now we have Dr. Parag Nigam, who is from the Wildlife Institute of India, who will be talking to us for a couple of minutes on wildlife, the ignored sector in One Health. Dr. Nigam, please.
So very good evening and a very good morning to everyone. Respected Dr. Renu Swarup ma'am, Secretary, Department of Biotechnology, Dr. Narendra Hegde, Dr. Subir Majumdar, distinguished scientists and officials attending the function. It is my privilege to be addressing this August gathering and speaking about a very important link in the overall concept of One Health, the wildlife, which has remained under the carpet for quite some time. And I really thank the DBT for having steered this whole symposium and the work. We all have now realized the impact of infectious diseases on our lives and the role wildlife play, either directly or indirectly. To start with, I would like to inform that the Global Risk Report 2021, released by the World Economic Forum, have ranked infectious diseases as the top 3 risks to human existence based on the impact. Definitely, prevention and control of infectious disease is of paramount importance to ensure our health and well-being. However, it entails better understanding of disease epidemiology, encompassing the disease triad with all the links to develop strategies for the effective management. During the past few decades, Earth has lost 1/3 of the forest and biodiversity, while the human and livestock populations have increased manyfold. The resulting degradation of the biodiversity due to human population growth, globalization, industrialization, and associated impairment due to pollution, climate change, geopolitics, and human migration have provided roadmap to zoonotic and emerging pathogens. So just to give you a brief, India is a mega biodiverse country with only 2.4% of land area and accounts for 7 to 8% of all recorded species, including around 59,000 insect species, 2,500 fish species, 240 amphibians, 460 reptiles, 1,200 around bird species, yes, and around 400 mammalian species. Conservation efforts are focused in our 981 protected areas in the country that includes the national parks, the wildlife sanctuaries, conservation reserves, community reserves, covering 5.03% of the country's land area. 65% of our protected areas are inhabited with 100 million tribals and 64% rural population, approximately 90 million livestock are dependent upon these forests. So just to give you, the size of 903 PAs out of the 981 PAs is less than 500 square kilometer. And when we talk at an international level, the Kruger National Park would be around 22,000 square kilometer. It's one of the parks, and that's how they manage. The small size of the PA, together with the large proportion of population still dependent on natural resources, results in an extensive spatial overlap between wildlife, livestock, and humans, leading to incessant interactions and opportunistic spillovers of disease both ways, exposing humans and the dependent animals to potential pathogens of wild origin and exposing wildlife to novel pathogens of anthropogenic origin. The scenario is fraught with inherent risk on both sides by providing common grounds for interaction, as is evident from sporadic disease outbreak on both sides of the spectrum. To expand further, I would like to inform the August gathering that wild animals in the intact natural habitats directly are not responsible for zoonosis. It is primarily the human behavior and activities that have resulted in closer interaction that result in sharing of pathogen between population, and similar to the spillovers which are happening and that we all have been talking about. Diseases having high zoonotic potential are basically mediated through vectors with greater role of non-human primates, rats, bats, and mosquitoes that harbor pathogens. And you are all aware of the arbovirus infections which are transmitted, Nipah, Hendra, SARS, even influenza, MERS are a few examples, and I don't have to be elaborating on. I would just discuss about one important disease, and that will really tell you the angle of wildlife into it. In India, we have the KFT, the Kyasanur Fall disease, which is a classic example. There were no reported cases of KFT prior to 1950s, as the virus remained restricted between wild animals and their vectors. However, biodiversity loss and fragmentation, expansion of human habitation, subsequent to intensive clearing of forest, of agriculture and timber led to tick vectors to discover alternative hosts, leading to emergence of disease in humans. What initially started as endemic disease is in a small patch in 1971, and now spans across several districts of Indian states, spreading several thousand square kilometers from the initial outbreak point. Rodents, shrew, non-human primates are common hosts for KFT after being bitten by the infected tick. The majority of efforts have been targeted towards human treatment, and that's all our efforts are. The epidemiological studies are limited. Such studies are quite crucial when you have to develop prevention, control, and management strategies, and definitely wildlife angle becomes a big thing. So this is just one example. There are many more wherein you have the wildlife component as part of the system. Carrying out systematic surveillance and monitoring is not that easy. It comes with a lot of challenges due to small populations in wildlife, limited information on species biology and behavior, difficult working conditions, scavenging effect of free ranging, making the availability of carcasses difficult, challenges in animal capture, administrative issues in getting permissions to work, limited capacities and infrastructures, and also the funding support. And I'm really happy that this consortium has now talking about including wildlife and really addressing those issues. In country as vast as India, with varied biography, following a rapid economic development trajectory, health concerns would be major concerns, challenges in near future requiring advanced preparedness and planning, synergistic approaches between different agencies for addressing emerging health issues, development of capacities of personals, provision of requisite infrastructure, facilitating intersectoral cooperation and coordination, and linkages among conservation scientists, natural resource managers, human and animal health physicians, scientists, public health scientists, epidemiologists. It is indispensable to tackle emergence. So I'm really thankful that the DBT has taken this effort. So while these efforts are going on, we need to really augment on these aspects, and it's a really very welcoming step. Just to give you lastly, the Ministry of Environment and Forest, under the Government of India, they have coming up with a National Referral Center for Wildlife Disease Monitoring and Prevention, for supporting disease investigation, disease surveillance, and capacity building for the people. And that will be coordinated along with other ministries. So this is a very welcoming step, and I'm really thankful to be addressing about wildlife, which had never been really focused much. It's difficult to work, but then it's not impossible. And these kind of steps would definitely make this area quite relevant. Thank you so much for patient. Thank you so much.
Thank you. Madam may be busy, so maybe she will leave in 5 minutes after Dr. Rawat says vote of thanks. But before that, it will be nice, Dr. Hegde, if for 20 seconds, Dr. Baljet Singh can say hello to Madam. Dr. Baljet Singh. He is Vice President, Research University, Saskatchewan in Canada.
Thank you very much. I am delighted to say hello. And this morning, my friend Jatinder Gill and we were talking about a pressing matter, and he did let me know the leadership that Dr. Swaroop has demonstrated in bringing it all together. He told me very clearly that without her national leadership and coordination with other agencies, the One Health Consortium would not have been viable or in a place of launching today. So I really am very grateful for her work and leadership. To me, it's personally very fulfilling because we began to collaborate in India with Jatinder Gill in 2010 on One Health. It's 11 years now. And to see that this movement has taken hold and it's actually really advancing the story on many, many fronts. So, Dr. Swaroop, thank you very much. If there's ever anything I can do to support the work that you are leading nationally, just call upon me. I will be very happy to support and do anything that I can. Thank you very much.
Thank you, Dr. Baljet.
Thank you, Dr. Baljeet, for this. I think the immediate support that we need from you is to continuously guide this consortium. I think that is the biggest support that you will give so that they are in the right direction and they continue to address, as I said, national and global challenges. So thank you very much.
Dr. Walker, he's director of vaccine and infectious disease in the same university. Dr. Walker.
Walker, have you joined?
Maybe he will join later.
Yeah.
Dr.
I think he was going to be a bit late by a few minutes. I think he will be joining us very soon.
Sure.
Dr. Swaroop, he is my colleague at University of Saskatchewan. He leads our vaccinology program. In Canada, we are the institute and the university that developed a COVID-19 vaccine, which is in human trials now. And Volker has been coming to India for many years. He been to Bharat Biotech, he been to Gadwasu many times. He is our long-standing collaborator with our Indian colleagues. And so someday we will come and see you together.
Dr. Manju Rahi, maybe we'll say hello to Madam from ICMR. Dr. Manju, she is Deputy Director General of Epidemiology and Communicable Diseases.
She had messaged me that she was.
No, she is there. She is speaking.
Yeah, okay.
Madam, unmute, please. We can't hear. Madam, we cannot hear you. Yeah, maybe you have unmuted.
No, not at all.
So probably you have to log out and rejoin. That is best.
Yeah.
Dr. Dinkar. So madam, these are the 4 speakers of today. And on 20 and 21st, we have more speakers from Australia and Europe. And 2 days we will be meeting for One Health, and also we'll have that symposium where international speakers will also speak. Dinkar, you have to unmute and say hello to madam. Not unmuted, Dinkar.
Yeah, good morning and good evening to everybody. And we really look forward for this epoch-making day because bringing 37 odd institutions together in India, I think requires a lot of credit. And thanks to Madam for really guiding and steering this forward, and to Dr. Subir and Dr. Hegde for being part to make this a reality. I really look forward to working with this consortia, and thanks for the opportunity, and all the best to everybody here. Thank you.
Dr. Manju.
Yes, thank you. And I'm switching on to my mobile phone, so the name may not appear. Yeah, greetings to all from ICMR side. And it's a pleasure to be here on this consortium. And I can't express my, enough that how important this is for all the stakeholders to come together. And Secretary Madam has really rightly pointed out a couple of things which are extremely important, and they need to be re-emphasized, that how it's important post-pandemic. And even though all of the organizations, including ICMR and DBT and DARE and ICR, have been working on for so long, but I think pandemic has taught us, all of us, to come together and work in tandem. And without duplicating other efforts, we need to be complementing each other and working in the same direction. That's a very important message. And ICMR will be very willing to work, and it will be very good to join hands, because all of the organizations have their own strengths and their forte of working. So like, I'll be very happy and glad to work together with the different stakeholders. ICMR has been working with all the organizations from past many years, which will eventually come in my presentation also. But I think it's a very good initiative, and this will keep the buzz around One Health, and we really need to take it forward. Thank you for having me here.
Thank you, madam. And madam, you have to wait for 3 more minutes. Dr. Rawat will give word of thanks. I know you can first.
Thank you, Dr. Subir, and good evening to each and everybody. I feel honored and privileged to have this opportunity to propose word of thanks on this special day. And I'll be very brief, because that time slot has been given to me only for 3 minutes. So first of all, I propose hearty vote of thanks to our secretary, Dr. Renu Saru, for gracing today's launching ceremony of One Health program of DBT and also delivering inaugural address. Madam has been constant source of inspiration for initiating and taking personal interest in this program. Thank you very much, madam, for supporting, and that I hope that we will be able to deliver in this project. Words are not enough to tell how this program became a reality, and it is only due to tireless efforts and dynamic leadership of Dr. Subir Majumdar, who not only brought the scientists from different streams in one platform, but also presented and defended this program several times. During my whole service period, I never found that any program which has been reviewed a number of times, I think 8 or 9 times this program was reviewed and then came to the final stage. Dr. Hegde, Director NIV, is one of the main architects of this program, who worked with collaborators as well as with Dr. Majumdar as a team and make it successful. I also thanks all distinguished speakers who have already spoken and those who will be delivering talks post inaugural session. As madam told, this is an inspirational opportunity and journey has just begun. I request each and every collaborator of this program to contribute and make it successful. I appreciate hard work of DBT scientists, Dr. Jain, Dr. Vamsi, and particularly Dr. Lokesh Nanolia, and staff and scientists of NIAB for making the day. I thank each and everyone for attending this meeting. Thank you very much.
So,
thank you, Subir. In fact, all of you, all good luck, and I will log out now, and all the best for your symposium.
Thank you, madam.
Thank you, madam.
Thank you, madam.
So I think we will directly go into the symposium, since we do not want to keep Baljet waiting. So I think Dr. Prasad Rao and Dr. Abhijit Deshmukh are going to conduct this. So Prasad, take over, please.
Yep. Thank you, everybody. So we'll move on to post-inauguration session. On behalf of NIAB, we welcome all national and international eminent speakers, participants, colleagues, students, and online participants to this mini symposium, Essentials of One Health. So today, in this post-inauguration session, we are going to listen from 4 eminent speakers about One Health. So I'll begin with our first speaker. He's Dr. Baljet Singh. Just now, everybody has introduced. He's an accomplished researcher, educator, and administrator in the field of veterinary medicine. He has done his bachelor's and master's in veterinary science, Punjab University, followed by PhD from the University of Gulf. Later, he did his postdoctoral training at University of Texas. Followed by he moved on to Columbia University. Further, he completed his licensing requirements for the Canadian and American Veterinary Medical Association. He has served as the Associate Dean of Research at Western College of Veterinary Medicine at University of Saskatchewan. Later, he moved to University of Calgary. Dr. Singh has his research focused on cell and molecular biology of lung inflammation. He is the author. He has authored and co-authored for more than 100 papers as well as books. He has supervised many researchers as well as trainee students, as well as postdoctoral students. He has received several awards, including a lot of teaching fellowships, as well as Provost Prize from Innovative Practices of Teaching and Learning. One of the best award, I would say, received Outstanding Veterinary Anatomist Award from the American Association of Veterinary Anatomists. And also he has received Pfizer Award for Research Excellence. So with this introduction, I'm going to invite Dr. Baljet Singh to deliver his talk on his talk of his title is One Health for Complex Problem Solving. Thank you very much. So now Dr. Baljet Singh, you can take over the mic. Thank you.
Thank you so very much for this introduction. And let me share my screen. And now just let me know, do you see my screen with the slide?
Yes.
Thank you very much. Sometimes it's always problematic. Let me get on with first thanking all of you, and you are my dear colleagues, and all the work you do at the local and the national level through your research, your leadership, and the development of this type of collaboration among various institutions is very commendable. Not an easy thing to do, but I'm sure your personal attributes of collaboration and sharing the success with everyone do help in making it possible. So the question which I always pose is as to why do we do things that we do? That is the question. As a leader, as a dean, as a vice president, I always say, well, if I'm going to take an action, why am I doing it? That is the critical piece. Same thing, One Health, we know what it does, but the question is, why do we need it? And then what does it allow us to do, which other ways of doing something will not let us do that? That is the fundamental, deep psychological and the behavioral question that we have. Many of you in senior roles possibly have heard these things before, but there are many young scientists in the room. So quite often my conversation is directed with them. And so I appreciate it. Jitendra spoke to me this morning. We were discussing a pressing issue, Jitendra Gill, and he again talked a lot about the consortium which you are all launching today. So this is the summary of some of the collaboration that we have done since 2010. It began with a very small project with $150,000 in total, and it led to development of, I think, by now, 3 CREATE programs. These are Canadian nationally funded training programs. There's a third one which is running now with Gadwasu. A total of maybe $10 million have been secured so far, about $1 crore. And so it has been quite a fruitful collaboration. And now congratulations to you for the launch of the One Health Consortium. So a very long-standing quotation is that that if you, from a pile of sand, you take a little grain of sand out, it changes things. Now, we know that there's a pile of sand. अगर आप वहां से मुट्ठी भर के भी कुछ उठा लोगे तब भी मालूम नहीं होगा कि जहां से कुछ गया है. लेकिन you could not determine it at that point as to by removing that a single piece is going to have a very profound effect. And the effect of doing something very simple becomes very visible over a period of time. So it's a very generational thing. Whatever we do today at a systems level at something very fundamental, something very basic, is going to express itself in a very positive and a negative way a few years from now. A simple example, the collaboration that we began in 2011, we never began it by saying we will build a One Health consortium. But that simple beginning did lead to the building up of a consortium. Dr. Nigam was talking, things which have been done 100 years ago are showing up now because of the emergence of a disease which was previously contained within the forest. So when we tweak something, when we change something, its impact will be visible down the road at some point. And that's where the butterfly effect comes into play. So there are old standing concepts where physics was supposed to be governing the nature. When Newton said that everything in the nature works according to the laws of the physical matter, therefore we can predict everything as to how it will work. 1 + 1 will always be 2. Molecules will always be arranged in a certain way. Therefore, we can predict what will happen, including in the nature. Similarly, that idea kept on growing. And Pierre-Simon Laplace again said that in the universe, when you apply the laws of the physics, there is nothing left for guessing. There's no unpredictability. You can predict everything. This was the level of confidence, actually hubris, that the scientists had, because physics was developing in a way where the man or the woman said, we can control nature. Then came a very simple idea about 60 years ago. Actually, it came about 200 years ago from Alexander von Humboldt. But then later on, the idea became the butterfly effect, that you do something in Canada today, it will have impact in India or somewhere else. Because the systems are linked to each other at a very molecular level, atomic level, and a very large system levels. And when the systems are linked to each other, they are not static. They are moving all the time. They are rearranging themselves. That increases the number of variables in the system. When the number of variables goes up, the unpredictability takes place, and therefore we cannot predict what will happen when you move a single piece out of the hundreds of pieces as to what the domino effects would be. And the systems are very sensitive. They may not look very sensitive. A stream of water flowing by a village may not look very sensitive. There's a water that comes from the mountains. It flows out to the fields, but it's a very sensitive system. We do something today, we will see an impact 10 years from now. And the problem is that the effects are unpredictable. Neither we can predict a positive outcome, nor we can predict a negative outcome with a very high degree of certainty. So what it tells us, that nature has very complex, interdependent relationships. And a linear system, such as 1 + 1, 2, cannot resolve those. So where does that leave us? Alexander von Humboldt says that in this great chain of causes and effects, no single fact can be considered in isolation. So that's where the collaboration comes in. So continuing the discussion as to why do we need One Health, what is at the fundamental level that we are trying to understand, then we look at the complex systems. A complex system is something which is going to develop over a period of time. In a country like India, where we always talk about thousands of years of civilization, but we never take a moment to stop and think that it developed in a manner over a long period of time. There's a history behind it. And as we can look back in the past, we say, oh gosh, we never thought it would happen. Same thing would happen in the future. We will say, well, we don't know whether it will happen or not. And the system itself has lots of knowledge in it. The system of any society has lots of knowledge in it, but the problem is one single individual knows only a small, tiny part of that knowledge. So unless we gain the knowledge which is present in the system together, we will not be able to use it to develop some strategies to solve problems and make the better future for all of us. Now, if we go further, what are the other characteristics of this system? The system develops over a period of time. There are 4 other parts of the system. They are called volatility. Because it's interconnected, it can become volcanic very quickly. It can react very quickly. And it's uncertain. We don't know how it's going to react. We did not know how COVID-19 is going to come. We are still finding explanation where it came from. How did it spread? We don't have an agreement on that. And because it's a time-dependent dynamic system, it is inherently complex. And the ambiguity is something when something is not very clear. So therefore, these systems, which are volatile, uncertain, complex, and ambiguous, defy a single definition. We cannot define it. Even when we define One Health, that definition is not complete yet. The connection between animal, human, and environmental health. Unless you link it to the social science, the policy piece, the One Health is not complete. So again, just highlighting a definition that we use all the time, we need to appreciate that that definition is incomplete. So we are looking at systems developing over a long period of time, multiple parts, very complex, very unpredictable, very ambiguous. So what do we do with them? So when the problems emerge out of the systems, how do we solve them? So there's a process to the young students and young colleagues in the room. So as the system has developed over a period of time, and the problems that are associated with the system, you just cannot solve them in a single stroke. You will need to tweak the system. As you took a piece out of the system, you will need to put that piece back in the system at a place where it needs to be today, and then wait for some time so the system can recalibrate itself. People say, well, we have all the vaccines now. Why are we still dealing with COVID? Because it's a very dynamic system. New strains of the viruses are emerging, and therefore we cannot eliminate the problem. So it's a dynamic system. So spending the time to understand the knowledge from within the system, to identify the problem, then have the openness, bring the right type of people, and to describe the system first. Sometimes because of the pressures of time, emergency, we jump into solving the problem too quickly. While the first step has to be taking the step back and understanding the system that is being affected and altered and is not working well. So take the time to study the system and get the knowledge, because system itself will tell us as to what do we need to do to solve the problem. Now, it's a multi-step process. So the first thing is understanding the system, then understanding why it is not working properly, then understanding the barriers. If we are going to do something to solve the problem, what are the barriers in front of it? Do we have enough money? Do we have the drug? Do we have the delivery system? Do we have the people on the ground to go and talk to the patients? Can we print pamphlets to send to every village and city? How to prevent yourself from a disease? Those are the barriers between what we have now and where do we need to get. So when people are involved in the system, when I say system, I'm not talking about a machine itself. I'm talking about the physical system, the living system, the matter of life, and it all together makes a system. And when people are involved in something, we have to pay attention to their behavior, their cognitive characteristics, the psychology piece, the sociology piece. How come a group of people living in Bihar, they may think differently compared to a group of people living in Hyderabad? We need to be able to understanding those behaviors which are driven by centuries and millennia of life going back, and then defining what we do today is actually defined by multiple generations before us. And then develop the strategy to overcome these barriers and then put everything together. So again, I'm taking you very slowly through each of the steps as to what it would take us, first beginning with how the system gets changed, then how do we need to understand the system, and then where do we go? Now, when you have studied the system, you have the data, then I want to bring the last piece of complexity. If you read War and Peace by Tolstoy, there are two characters in that book. One of them says, if two armies are fighting, the war goes like a chessboard, where the queen goes, where the pawn goes, where the rook goes, and then you can predict the outcome of the war. The other character says, my friend, you are a fool. In the real war situation, most of the time, every plan falls apart. When the horses come charging, when the tanks are firing their bombs, you just cannot predict the outcome of the war. The reason for that was a German philosopher, von Clausewitz. He says in 1800 something, that the reason for that is that at any given time during a war, you never have more than 30% of the information that you need to either defend or to attack. So if during the time of COVID, we have only 30-40% of the information, which is growing, how do you make a decision? So we need to live with the feeling that we do not have all the knowledge that we need today to tackle a problem. So it is ability of our group as an individual to make a decision with all this complex, fast-moving, unpredictable, volcanic, ambiguous system, that we also don't have all the information on the system to make a decision how to intervene. So that's where One Health comes in. So One Health needs, we need One Health to do what I have been talking about for the last 10-15 minutes now. So the system that some of you have described, the close connectivity between animal, human, and environmental health. You take one piece out of it, for example, you cut a single species of trees from the forest. Few years later on, you will figure it out that something has changed. You may not know it today, but 50, 70, 100 years from now, something will happen in that forest, which may be good, may be bad, we don't know that. And everything we do is linked to the social behavior and the public policy. If the government does not make the public policy, then we cannot make the impact on the people with whatever we plan to do. And everything is very global now. Dr. Volker Gertz is going to talk about his work, which is very global. You all do work in biotechnology, which is very global. So I think we are deeply connected with each other, and that impact is very clear as well. And finally, our collaboration has to be very true. Quite often, when we build consortium, every university begins to think how much money we are going to get. The question has to be, what are we going to get with all the money that we have received? More money gets wasted because it's broken down into small pieces and given to multiple entities than if the money was put in one place and given to projects. So I think we need to change the system, the way we work. Whenever we did One Health School at Guru Angad Dev University, Jatinder would always say the first question, I am going to open the school to my colleagues from across India. So his passion always was that I want everybody to work together, present their papers. I want to bring graduate students from every veterinary college in India. We can't bring all of them, but maybe 2 from each college. I want to bring assistant professors from other colleges. And that's what he always did. And that's what we all should do. And together in a very collaborative way. So please use One Health. You are going to talk a lot more about One Health, but I have laid out the problem, which is very complex, and how we can solve it in the coming many, many years. And last point is, congratulations to all of you. Thank you very much. And I hope when the COVID subsides, we will do a symposium in person somewhere in India. And Dr. Gertz hopefully will come with me, and we will get together again. We will begin our student exchanges, faculty visits, as we used to do till about 3 years ago And I cannot wait for that. I have 5-7 minutes. I'm happy to take any question that you have for me. Thank you very much.
Thank you, Dr. Singh. Thank you, Dr. Singh. Now the talk is open for the questions. If anyone has questions, maybe we can take 1 or 2 questions.
Yeah, great, Dr. Superb talk and really very inspiring, because it is completely different from what we look into One Health and do. It's a lot about management of it. And I believe what you said is quite correct, that this is not 1:1, is going to be 2. And there has to be a lot of issues taken, that the same people, not only what kind of genetic background they have, but also what kind of food they eat, what kind of job they do, what kind of friends they have, and what are their health and hygiene practices. So typically, I have only one question. How you said that this solver's cognitive ability is extremely important. And same is true probably when the solver goes to a war, his cognitive and understanding and kind of forecasting something in his brain is important. That means, are you suggesting people with a lot of experience and expertise who have already faced this kind of situations are going to be very, very important to be incorporated in this kind of projects? Very experienced people, because one who has done a lot of wars, one who has gone through very tricky situations and understood things well, I think those people must be involved in such kind of One Health programs, which means we have to be very choosy in incorporating people for the success.
The point, you have already answered your question yourself. The what I was taking as an example, the main piece is that we need to bring people from social sciences and humanities into the discussion, people who have expertise in developing scenarios, people who can understand and the behavioral aspect. Some people will jump at solving a problem very quickly, which doesn't help. Our ability to take a step back and reflect for a moment and say, okay, what am I trying to do here? And then say, do I have all the information that I need? Do I need my neighbor to come and help me to get my car out of a ditch? Or can I do it myself? And so all those very simple questions, sometimes in our gatherings, we hardly ever have somebody who's a psychologist, who's a sociologist, who's an economist. We need to bring those in. And I think you've already answered your question. And any young assistant professor or graduate students in the audience, if you have a question or two, happy to take from you as well.
Any questions from grad students who are sitting here? You can ask anything.
Yeah, I mostly enjoy their questions, but they're very fresh. They make me think differently after I listen to them.
So,
Dr. Subir Majumdar will give you a prize if you ask a question.
Dr. Singh, I have a question. So when we talk about, pooling all the young students like these, or you're talking about assistant professors, all these people, particularly when we talk about biologists. So how to motivate them to join in these kind of One Health related programs? How do you deal with this, particularly in your consortium?
I think the leaders in the consortium are in the room. They possibly have plans how to do maybe summer institutes or programs and invite students. They already have. I know they must have made plans in place. But the sense of collaboration, you ask a question again, sometimes students, that's why I always focus a lot on students in One Health schools, because to bring them to the front, to let them ask questions, let them lay out the problems. And whenever we develop a One Health school program, I always bring students to the front. So I think to keeping them more engaged is what it is, because I don't know what more I can do in my life. Next few years, I'm going to wrap it all up. So the future lies in the hands of people whom we enable, we guide, we prepare, we give them responsibility, and then they can do better things. At this institute in Leipzig, Germany, where I'm sitting today, and people are doing massive amount of work. They are looking at soil samples from 142 countries to compare the microbial composition, the chemical composition, the nature of the soil samples, and it's a massive project. They want to just have information on the soil samples from around the globe. So this is the type of work we need to be thinking about doing. And really openly engaging our colleagues and our students and our policymakers. And I cannot tell you how delighted I am that you have been able to secure funding for the consortium. You will look back on it 5 years from now that this was a major achievement of your career, to really get collaboration among all the leaders that you are in the room, and then work with the government of India to get the funding in place. Let us work together to make it a great success. And so that's where we should be focusing now. And then that's where I would be always very happy to be with you, and any way I can help out. Maybe last question before I go.
Thank you. That was wonderful. Yep.
Dr. Baljet Singh, I have one question. So people always say that when you have a complex problem, divide it into simpler things and try to address the simple ones. What is your take on that? Relating
that's one of the most critical steps in the problem solving. But the question is, we need to put it back together too. And even the breaking down the problem is very critical part. How do you break it down? In what type of pieces do you break it down? And so I think maybe at one of the next school we do, I can happy to spend some time talking about it. There are even people who know far more than I do. I can bring one of them, but I will be very happy to maybe do a session on that. How do we do most of my methodology, even anatomy, think about that, was built on that problem solving. I will say, well, if you cut the radial nerve, what's going to happen to the limb? Work from there. You will never forget after that. In India, we spend time, radial nerves come from there, it goes here, it goes there. It just doesn't make any sense, right? So I think the functionality of the system, Dr. Hegde, is, you all know that. I think you're asking me questions so that the students can listen. You know it also. So I think that that's a very critical piece. But overall, the collaboration develops over time. Look, it has taken a long time for all of you to achieve this success. Not easy. So I commend you. I keep on saying it over and over again. It is not easy to do these things, but you are doing great work, all of you. So congratulations to all of you, and thank you very much.
Thank you, sir.
I wonder if Dr. Volker Gertz have joined us yet or not.
Dr.
Not
Volker?
yet.
He will join.
No problem.
He will join. Okay, thank you so very much. And I hope to see you all very soon. And we will plan something in Saskatoon too next year.
Definitely. Definitely. Thanks.
Thank
Dr.
Thank you. Thank you.
Thanks for
Thank you very much, Dr. Singh. Thank you very much. That was indeed a wonderful talk.
Thank you.
We will
Thank you
invite you in our next meetings for any review meetings or other when we are going to work on this project. After doing some work, we will have your guidance in this consortium.
But considering the problems I'm facing now, I'm just going to come back to the village, as I was telling you this morning.
Okay.
Thank you. If no more questions, thank you, Dr. Singh. Thank you. So today, in this post-inauguration session, our next speaker is Dr. Manju Rahi. She's a trained clinician by training and scientist staff, and Deputy Director General at Division of Epidemiology and Communicable Diseases, Indian Council of Medical Research, Delhi. She did her MD in Community Medicine and Postgraduate Diploma in Epidemiology from Government Medical College, Miraj, Maharashtra, and Public Health Foundation of India, respectively. She's a nodal person for the implementing research schemes on a number of vector-borne diseases like malaria, filariasis, leishmaniasis, and zoonosis. She also works closely with various overseas partners, such as London School of Hygiene and Tropical Medicine, Bill and Melinda Gates Foundation, World Health Organization, and Monash University, and others. So in order to improve Indian biomedical research ecosystems, she is steering in many research programs having policy implications in above mentioned research fields. Today, she's going to talk with us. Her talk's title is Striving Towards One Health, Researchers' Perspectives. Ma'am, you can take over the mic, and you already shared your slides. We have your slides. We'll start them. Thank you.
Thank you. And I'm surprised at that introduction. It must be from maybe some website. In short, I'm basically a public health person, and thank you for inviting me here. And as I said earlier, it's a very important initiative that all the stakeholders come together. I was just looking at the list of the participants here. And I mean, again, it's a little skewed to the animal side, the veterinary side. So I think it's time we need to broaden the dialogue. But having said that, I think each step is an important step. And as Dr. Baljet said, it's critical to break down a complex problem into smaller problems and smaller steps so we move ahead. I hope I'm audible in the system. So maybe without wasting a lot of time, I'll be just focusing on, mine won't be as philosophical and broader as Dr. Baljet, but I just want to bring the focus back to the researchers that when we say that One Health issues or the emerging pandemics and actually COVID-19 has brought the focus into emerging threats and diseases from the zoonotic origin, how SARS-CoV-2 is of zoonotic origin, but then became human-to-human transmission. But this has brought focus to preparedness, focus on the emerging infections. And I think we can bask in that attention and bring the focus of the scientific community to zoonotic infections, which somehow many of them are neglected, many of them are not talked about. Bacterial endemic infections are just are not on the forefront. Even the researchers don't give priority because a lot of funding won't be there. When I deal with vector-borne diseases, especially like something like Kala-Azar, visceral leishmaniasis, and lymphatic filariasis, because a lot of buzz is not around because it's a poor man's disease and a lot of funding will never pour in. But so that's how some of the even zoonotic infections are, which I'll go through the journey. But coming back to the perspective from research angle, and research is not just simply the blue sky research or a leisure science to be done, but it's also responding to the threats of the emerging infection, responding to the needs of the country and the globe. Maybe now with COVID-19, like I think it's a global village. Vaccines traveling to other countries, diagnostics, importations. So everything is happening in such a dynamic manner. Now nothing is national or nothing is, one country. So moving on, I'll just quickly glimpse through what ICMR has been doing in this space. And I've been handling zoonotic infection. It was earlier called zoonosis. Now we have expanded to One Health. We have evolved ourselves. I remember the first meeting with, when I took up the program in 2010-11 with ICR. I mean, Dr. JPS Gill has been with me in this journey from throughout. ICAR and Dr. Gill have been our members of the joint ICMR-ICR panel from past many years, I think more than a decade now, how things have evolved over time. And that's how also it should be. And now we are in a much maturer stage to handle such programs, and we have come a far way now. So I'll just quickly glimpse through what ICMR has been doing in this area, and where now actually we should be going on with a lot of partners and not just looking inward. We should be looking outward and involving as many people as possible. So this is just a snapshot of what is ICMR, and this is ICMR's headquarters departments, but that is how the spread out of ICMR is in India, and maybe much more granular level because there are many field stations of our institutes which are spread out to smaller cities in India. Next. So I don't know, I don't need to tell these basic stuff to the August gathering here. All of you are stalwarts and luminaries in this work. And but the most important point I would want to underline here is that the collaborative mechanisms are the most efficient ways to deal with these kind of threats and infectious diseases, where the the paradigm of all the three animal health and interface of environment and we require an interface of all the environment, animal, wildlife, human, and Dr. Baljeet rightly pointed out, we need social sciences, psychology people. So everybody needs to come together. So this is the most efficient way to, handle these and successfully mitigate these infections. So all these departments and all these people need to come together. Next. Anyway, so this is how the spread out is. I have borrowed this slide from Dr. Maurya, who has been a champion of viral infections from NIV Pune. And this is how the spread and how have they been detected first in which country. So these are the multiple emerging and re-emerging infections since 1998. Next. So no country is untouched. Next. India has been battling with these, and in addition to many other countries, these emerging infections. Actually, viral emerging infection has taken a lot of limelight, and they have brought into highlight these zoonotic infections like pandemic influenza, MERS-CoV. Now COVID-19 has blown off everybody. Nipah virus, which was again in the news 1 month ago, Ebola, Zika virus, CCHF, KFD, all these are in the background. The outbreaks happen, mortality happens, but they are happening in animals, and there's a joint surveillance systems. So these are there in the background. Next. So, and in addition to what have been listed, there are many other unidentified viruses which NIV Pune constantly works on. So maybe that's how where the preparedness part comes when we identify these viruses, the diagnostics, development of treatment strategies, development of vaccines. That's a constant research and R&D which needs to go into it. And of course, one institute and one organization would be insufficient to do it everything together. So that's where the consortium, where a group of organizations and minds would be required to delineate who has to do what, and multiple groups working on these strategies and tools. Next. So these are some of the 13 important zoonotic infections. Some are bacterial, some are viral, some are other organisms, and some are endemic, some are of epidemic and outbreak potential. So majorly these have been listed in the literature and of varying importance. So order is just like that. So it can, like COVID-19 can take up, something like Lyme disease is not talked about in India, scrub typhus, rickettsial infections. So these are majorly important, which capture our priority for research. Next. We all understand these are the gaps which we thought of once we made a document on One Health. We don't have adequate data as well. We don't have burden data. We don't identify how much population is suffering from these infections. So once we don't know the burden, we can't identify how much resources would be required. So the first step would be to have burden studies and to have surveillance data. There's requirement of convergence of surveillance systems from animal side, from program side, from environment side, so as to have an alert and the early warning signals from the animal side as well as human side. So also there is limited sensitization of the authorities and the community. People don't have now because of COVID-19, there's a lot of sensitization and people are on a hyper mode, like how people are very sensitized for dengue. But if you say 10 years ago or for chikungunya, nobody would have heard about these diseases, or 15 years ago. Now everybody knows that din mein machhar kaatega dengue ka. So that's how the social awareness happens when things happen on the ground. So there is lack of appropriate programs because these diseases are never talked about, which comes from and of course, there is a major part of novel pathogens which keep on emerging. And now with, I think, a lot of media awareness and social media and everything is on internet. Now, at least the awareness part is not a difficulty, but the right information reaching people is still a major challenge in terms of this media availability of information. Next. So we all understand what is One Health, and there are definitions by WHO where everybody has to come together for the ultimate goal of better public health. We all work together, and there are common intersectoral areas where there is convergence of all these stakeholders. Next. So talking about I'll be going backwards in a chronological order, how our imagination or how all our work has been affected by SARS-CoV-2 and ICMR. My other colleagues and groups in ICMR have been working towards the mitigation and control and response to the COVID-19. And it has taken the world by surprise. And I think after now will be almost 2 years. My daughter keeps on reminding me, she's 12 years old, that it be now 2 years that we haven't been to school. So that's how now we are grappling with the reality of dealing with COVID-19. And I think fortunately with vaccines coming out now and a lot of population, even in the developing world, getting vaccinated, we can see a ray of hope at the, and there's light at the end of the tunnel. So this is how we are moving on. Next. So, I mean, in short, there's no need to go on and on about COVID-19. All of us are struggling with it, but ICMR in a very pertinent way has contributed majorly in handling the situation in India and abroad. So the testing from one lab in NIV Pune, which is our nodal lab for viral infections, the upscaling of testing has been expanded to 3,000 labs across India, which also includes private and government labs. WHO, ICMR also participated in clinical trials, which are very important from public health point of view and from giving treatment strategies to the world. Placid trial, where the plasma therapy was discussed and it was not found to be useful. WHO solidarity trial, the role of BCG vaccine in COVID-19, and many other, we were seen. Vaccine development and deployment, surveillance. So all these things, different groups in ICMR have been working overtime, and past 2 years I've seen a lot of work in these areas. Next. So anyway, so these labs have been expanded, and so all this work has happened. Next. So now, as I told you, 3,000 labs are there. RT-PCR have been expanded, TrueNAT machine, CBNAT, RTP, and where the PCR tools were supposed to be only for high-end laboratories, which are resource intensive. Now it has reached the nook and corner of the country, including the difficult terrains in the Northeast or Leh Ladakh. Next. So this is a vaccine, is a very major tool which has led to a halt in the spread and transmission of the COVID-19, which hopefully we will be able to see the impact when we say about the third wave. And there's always experts will say now the rate of vaccination has gone up so high, and with the immunity also going up so high. So hopefully, and I pray that what we suffered in second wave, that doesn't happen. The numbers don't shoot up that way because of the vaccinations. So Covaxin, our indigenous vaccine, has been the front runner for the vaccination. Serum Institute's Covishield, which ICMR also contributed in doing the trials. Zydus Cadila also received approval, and very recently Covaxin has been approved for use in children. So I think there is a lot of buzz on vaccine side, and Indians, though it began with little tepid speed, but now it has picked up real well. Government has really saw to it that is the corner of the country, and now with drones delivering vaccine, I think we are doing very well in vaccine delivery and vaccinations of our people. And with a huge population base, this is no small feat. Next. So all this has been published. So this is a very dynamic website of ICMR where all the COVID information is there, and all information is available in a transparent manner, and all information is accessible. Next. So this was all about COVID, where all of us have been very preoccupied with from past 2 years, and it has halted a lot of our normal research work. Like I work in vector-borne disease infections as well. A lot of my malaria and other disease infections work has been halted, but gradually we are picking up speed. Coming back to the other zoonotic infection, which also take up a lot of our research funding and our time and institute's resources. I'll just quickly go through them. Like NIV Pune has been, along with the other institutes, have been working on KFT. I don't need to go through the infection. Next. So NIV Pune ICMR Institute was at the helm of affairs when doing sero survey, when developing the diagnostic test for the KFD. And that's how we have now at least recognized that it's a public health, it's a disease of public health significance, and we need to develop some good, robust programs for KFD and so on for CCHF also. Next. So these all are emerging threats. If we don't keep an eye on through robust surveillance, they can result in an outbreak situation, which has happened in the past also. So NIV Pune has developed the diagnostics for animal as well for humans, and they've been translated to the companies. Next. So this is the overall situation in the country for the emerging threats of KFD and CCHF. Next. So Nipah, all of us are aware, it was a very major threat in 2018-19, and Kerala has been, I mean, very recently also, amidst the rising COVID cases, and Kerala really had a high number of cases of COVID-19 because they were reporting also and they were testing very well. Nipah also again a threat, and it came into limelight again, which was curtailed very well, and luckily it didn't spread too far. So a lot of animal surveillance also needs to be done. NIV Pune, with the help of the animal husbandry and animal department, has been able to do this surveillance of bats. You can see our team capturing a very huge pteropus bats. Next. So these are all the spread out of the where from past many years they have been recording positivity in bats, but spill over to humans happened recently. Next. So I'll not go on more. This NIV's work on Nipah has been in news and it's all published. So it's important to keep human and animal surveillance in tandem for these emerging infections. Next. So this is about CCHF and KFD. So this is an important point when we say research should not just stop at research. What we need is also capacity building. We need capacity building for outbreak identification and investigations at the right time. We need capacities for preparedness in the terms of diagnostic, good surveillance system, good communication, which has to happen in real time. So, and this will happen only when all the organizations and all the stakeholders, like today, they come together on one platform and they communicate with each other with a lot of convergence and in real time. So there we need digitization of our systems. Here we need real-time data flowing from one stakeholder to another. Next. So Zika is also one of them. Next. So ICMR also played a lot of part in Zika surveillance. So I remember ICR's Nivedi Institute, and we tried to converge the surveillance systems. They have a beautiful NADRA systems where they do alert and in the animal population. That's how we need to converge our NCDC's IDSP surveillance system. So from research side, we can develop surveillance models which can work the best, the real-time surveillance models. But here we require a lot of communication. It's not only just ceremonial, convergence or just once in a 6 months kind of a dialogue on One Health. It has to be a dynamic process. So coming to the other works which we are doing on One Health. So which are the diseases which we usually don't talk about and which usually don't gain attention. We are picking up in our task force studies, and Dr. Gill has been helping us in designing this study. One of them is a multicentric Lyme disease, which we have launched along with AIMS. So again, this is a neglected study which, like scrub typhus, like rickettsial infection, till you scratch the surface, you will not find. So this has been recently launched, but halted by COVID. Again, we have picked it up at multiple sites. So there'll be a flowing paradigm of tick surveillance to human, to community. So we are covering the disease end to end. And some of my colleagues from our ICMR Institute who are partners here, like RMRC Dibrugarh and Northeastern and Nigrims, Meghalaya, they are together here. Next. So along with NCDC, we also took an initiative on human rabies, where as I said, burden estimation is a big gap. So the last rabies estimation burden was done in 2003-04. Again, this will be attempted now, halted by COVID. Again, we have picked it up. So this will be the first study where we'll be doing the real-time estimation of animal bites and estimation of the human deaths. Because, it's a preventable death, yes, but if the infection is there, it's 100% fatal. If it's not prevented, post-bite prophylaxis doesn't happen. So this will be done by NIE Chennai at multiple sites in India. And yeah, next. Just give me 1 second. Just don't give me one. Sorry, somebody from, it was an important call. I'm really sorry for this interruption. So in addition to the Lyme and to rabies, we are also venturing into in a major way into anthrax, because this is an outbreak prone disease and the most marginalized tribal community gets affected by anthrax. So RMRC Bhubaneswar is playing a very pivotal role in developing strategies, not only for developing diagnosis or diagnostic capacities in the state, but also in the community, the awareness about how to deal with the CARA cases. Dr. Baljet rightly pointed out about the social and the behavioral aspect of people. So these tribal communities will have their peculiar habits where they need to be told and informed about. So this is all happening in Odisha. So after this Anthrax study, now this is almost completed, we are launching another multicentric throughout India Anthrax study, where we will be demonstrating strategies to control. A model will be given to the program, where along with the state program, research bodies can contribute in its control. Next. And as I said, I'll be traveling back in time. So now today I'm suddenly reminded of the close collaboration. Of course, it's a dynamic and very, very on-the-go collaboration with ICAR, where not only zoonotic infection, but food safety. And Dr. Renu Sarup talked about antimicrobial resistance is an important area. So AMR and use of pesticides, nutritional supplements to counter malnutrition in India are the focus area of this collaboration with ICAR. So this MOU happened in 2016, and with ICAR, with our honorable ministers there in their presence, where we commit to the joint work with ICAR. Next. So and under that collaboration, we have worked very closely with the Nagpur institutes, Nagpur Veterinary College, Mahatma Gandhi Institute of Medical Sciences, Wardha, and Central Institute, where we launched for 3 years a very large task force study working on selected zoonotic infection. One of them was rickettsial infection, and brucellosis, which affects a lot of the rural population, and it's an economical burden also on the dairy farmers. Next. And also in collaboration with ICMR, we launched a very special program on mixed farming along with RMRC Dibrugarh, our partner here. So where the Northeast the population in the Northeast has a peculiar practice of having mixed farming, where the livelihood promotion promotes that they should have multiple types of animals in one ecosystem. But unfortunately, that gives rise to spread and jump of the species of the zoonotic infections. So this study has ended, and very, very good results are there. So we'll be planning a dissemination meeting of the study. Next. It's been published also. And leptospirosis, all of us are aware how different and difficult it can happen, especially in Mumbai and these areas where the monsoons are really, very intense. And every year there will be leptospirosis outbreaks. We need to work on the rapid diagnostic kits, and a lot of sensitization is required. So this World Congress happened in 2019. So I think we require more of these events where the buzz is created and attention is created to these kind of infections, which usually don't gain attention. Next. So coming to the last point, which has also occupied space in the speech of our Honorable Finance Minister in our budget speech, where One Health gained so much of attention. It was very heartening to hear. And so we are very happy to announce that the Center of One Health, which actually has been in discussion from past few years, but now it has gained momentum. So this is being constructed at Nagpur, which will be a BSL-4 facility, which will be an extension of NIV Pune in Nagpur. This is next, will be housed in MAPSU's next. Can I have the next slide, please? Yeah, so which is located in Maharashtra Animal and Fisheries Science University. They have given us land to construct this One Health Center, which will be actually a convergence of all the partners here. And we have been in very close collaboration with MAPSU, doing joint studies lately also on AMR or other things. Even before the structure comes into place, we have started a collaborative work. But once this infrastructure is in place, it would be become a hub for One Health research in the middle of India. So next. So with all these aims of not only capacity building and joint trainings and doing joint research. So this will be multiple dimensions to this One Health Center. Next is like this is very closely being monitored. Next, previous one, please. So this is being very closely monitored by Honorable Health Minister, and this committee has been formulated And as you can say, the chairperson is Honorable Health Minister, and all the secretaries of the important departments who are partner in our who are stakeholder and partner in this endeavor are members of this committee who will be very closely working with us. Not only this One Health Center, but One Health is a program from human health research side, operational research and implementation research. Next. So this is the one symposium we did, which was extremely important event for us. And I think this was the beginning where we spoke openly about bringing everybody together. This took place on 12th of April, inaugurated by Honorable Health Minister. This logo was created. Next. And also a special issue of IGMR was floated, and it contained all very important publications which gathered from researchers who have worked in this field. And we are very happy. This is available online. Hard copy is also available. So this symposium took place, and this special issue was launched. Next. So I think a lot of efforts have gone into, as Dr. Swaroop rightly said, that this is not the first time, like post-COVID, a lot of limelight is around One Health and all of us coming together. But I think the background is already laid. We just need to make it more intense, make it more frequent, make it more earnest, and we need to pull in all our resources, not only funding, expertise and infrastructure resources on one platform to make it a success. It has to be a dynamic, all the time kind of a dialogue. So with those thoughts, I'll end the how we have moved on in this journey. I'll be very happy to take the questions. Thank you.
Thanks, Dr. Rai. It was very, very important for you to come and interact with us and see this. So do you think that this is a little skewed towards veterinary science?
I mean, I'm sorry I said that, but I was just seeing the attendance.
No.
I didn't mean that the consortium is skewed. I mean the attendance, maybe that's where.
Yeah. You are right. Because if we go, can you unshare your screen?
I am not the one sharing.
Acha. Prasad?
I mean, it was just an observation that we need, and this happens even in our own meetings.
Yeah. Why I am saying, because if we can see this screen, this is just to show that we are little aggressive fellows, because we want to do something. So you see on the left-hand side, you can see it's about the veterinary centers, around 8. And on right-hand side, I think it's all medical centers, around 7. And people from all places are there. In addition to this, how it becomes 27 is there are 8 disease investigating units which we are trying to develop on the northeast border side, so that the cross-border diseases can be studied there. But it is our earnest wish to bring in as many medical personnel who can come in between, and participation with willingness to participate. That's very, very important, I think. So that's what I wanted to say, and I think please stay associated with us. And one more issue, one request is there, because I am seeing you live, so I can request. Several times there are good samples which are connected by the ICMR units. So if you can somehow influence the system, that there are people who are really talented, who can develop good kits, who can develop good vaccines. But if the ICMR can help us by giving those, sharing those samples, it will be a great help, because otherwise it will be a very big effort to do that. So this is a personal request. If you can help us in that regard, that will be really, really grateful.
I totally agree. And I don't need to even say this is, once we work in a collaborative mode, exchange of resources, including the biological samples and even the expertise, it becomes a two-way channel. So that would be, and all of us, I mean, the country and the population needs good diagnostic tools, good vaccines, good drugs. So till the research happens, and that wouldn't be possible if you don't share resources. I totally take your point. It's a very valid one. And once we move on with our consortium and our collaboration, this can happen. And I'm sure this must be also already happening, but yeah, we can always collaborate with, different organizations, yes. And my observation was only on the attendance list. I'm sure you have taken care of having a
No,
balance.
no, madam. What is the problem? We are trying our level best. We are very, very aggressive. We love each and every partner. We respect each and everyone. So somebody said that this is a NIAB One Health program. I said nothing. This is a consortium of DBT funded by DBT, but it's a consortium. Each partner will get equal respect. Nobody is hero here. Nobody is over smart here. We will all work together, and name and fame and everything will be together, and nobody is a leader. So, you know, all of us are leaders and everybody is equally respected. So that's the beginning. And I hope, because I have enough name and fame, Dr. Hegde is well known. So we too are running it. We want, both of us are trained in a manner that we mean something should come out of it. That's what is the biggest honor to us, not who gets the name or fame. With this philosophy, and we have very good leaders, Dr. Gill, Dr. Dinkar Raj, Dr. R.K. Singh, Dr. Rawat is also involved. These are very good leaders. So we have taken them so that they can always let people be jailed. Nobody should go out of this jail. So this jailing is very important, and our role is to work together. And it will be great if ICMR kind of helps us in growing together. And because this is obviously it's a medical and animal, wildlife, all problems. Thank you so much for coming, madam. That's very, very important. We are really so happy you have come.
And it's a pleasure for me and it's an honor for me to be here. It's really good, and I can see like all the right stakeholders are here who can actually take it forward. The attendance should not only be number or quantity, it should also be imparting the kind of expertise and quality to the work. That's extremely important. I'm very happy to be here and look forward to working with you and with the DBT as an organization and with all the stakeholders. And many of the people I've already worked with, we are funding some, we are working very closely with. I'm looking forward to working with.
Thank you so much, madam. If you come sometimes to Hyderabad, visit us at NIAB. And if
you go, we have our institutes there. Yeah.
Yeah, I know.
Thank you, Dr. Rai. Personal thanks for taking up on our invitation in a very short notice. Thank you very much.
Thank you.
Any other question?
Yeah, I would like to ask Anand here from NIAB. Dr. Manju, in your talk, you mentioned about ticks and Lyme disease, and so how much emphasis is there in ICMR regarding tick? Because if you see vector-borne disease, like the National Program of Vector Disease, mostly it's concentrated on mosquitoes. So any way we can bring ticks also in that?
Okay, so now here you're talking about two different things. Yeah, the national program, see, we are research body, right? So there is one national program which will take care about the management, diagnosis part and everything. So National Vector-Borne Disease Control Program primarily looks into mosquito-borne infections. So they take care of 6 diseases: malaria, filariasis, kala azar, dengue, chikungunya, JE. So, but as you said, tick-borne, mite-borne infections, they go with NCDC, even though they are vector-borne. But because more emphasis becomes on the pathogen they are carrying, which is virus mostly, right? Or sometimes it can be in other bacteria or some other organisms. But somehow NBDCP only looks after the mosquito-borne, more so parasitic and dengue and chikungunya viral infections. At ICMR, I mean, past few years we have been, 2013-14, I launched a large task force study in hilly areas for strep typhus, for rickettsial infection. In the Northeast, it's a major problem. In Gorakhpur, strep typhus was found to be a major cause of the acute encephalitis syndrome, which till now was called as a mysterious fever. So till you dig it, till you do the research or till you actually try to find it, you will not be able to do it. Same for Lyme disease. And we will, in fact, ICMR, NIV Pune has a very good repository of these ticks in Bangalore. Okay. So they have a very good museum. They have the expertise of the entomology as well. ICMR gives sufficient emphasis to these kind of so-called, they are not technically neglected like how kala azar is neglected, but WHO list, but these are not so talked about infections. I would like to give emphasis to them as well, because they will end up as pyrexia of unknown origin. They will be kept on getting treated as typhoid, malaria, nothing, hepatitis. People will end up in complications. Strep typhus, people die because they are not given doxycycline on time. It's a simple preventable infection, but a treatable infection. I would like to give emphasis to it, and we began a journey with giving a lot of emphasis and to rickettsial infection. if you just Google, ICMR was the first one to come up with the guidelines to treat rickettsial infection, scrub typhus, and we plan to do so for Lyme disease also, and we are picking up other infections also. I personally, as program officer at ICMR, I would like to give a lot of emphasis to tick-borne and mite-borne. We are also venturing into climate change and these infections, because eventually all these vector-borne infections are climate sensitive. Mm-hmm. So these vectors will have will be impacted by the change in the climate. So moving also in that direction, there is a task force which I personally am handling, is climate change and vector-borne infections. So that also is taking shape. So I want to converge these things in one go. Yes.
Thank you. Thank you very much.
I think there's a comment or question from Dr. Gill.
Dr. Manju Rahi, thanks for a very nice talk. We are actuated for a long time. But I have one comment. When we initiate the Center of One Health at zoonosis earlier at Nagpur, there was equal partnership of animal husbandry and medical. So in the coming days, the present shape, I am seeing that it is the all 90% medical and 10% veterinary. So I wish it should be a complete One Health institute, not a medical institute with the 1 or 2 veterinarians.
I totally agree, sir. And when you said you have been a partner in this journey from past 12 years now, maybe more than that. Yes, sir. You remember how it began with Center for Zoonosis, how it has traveled to this stage. Sir, when you said it was equal partnership, actually it was equal in the terms of funding. ICAR wanted to become, we envisaged ICAR would be an equal partner in terms of funding and administration. But somehow even the SFC was developed that way. But ICAR had to pull out of it because of administrative reasons at that time when Dr. Katoch and Dr. Ayappan were there, if you remember. So when Dr. Swaminathan took over, the minister said, you ICMR should take it on their shoulders, because you cannot have joint funding of one institute. It's difficult to control one institute administratively. So take it on your shoulders. So ICMR took it from the financial and administrative point of view. But sir, there is total academic and total scientific collaboration with our beginning partners are MAFSU, but we will definitely expand. ICAR is a close partner. Dr. Ashok Kumar, I speak to him almost once in every 3 to 4 days. So ICMR is a big partner, MAFSU is a partner, and I'm sure I take your word, sir. I take your point very well. It has to be an equal partnership. Otherwise, this has no meaning. Just doing 90% human medical research, I cannot justify myself I'm doing One Health. It would be wrong. And even with wildlife and environment, I take your point, sir.
Yeah. Dr. Manju and Dr. Gill, I just talked to Dr. Paturkar yesterday for something else, who is Vice Chancellor of MAFSU. Yes. And I raised the same point to him because it happened that once Dr. Bhargav and myself were with the Minister of Health, and as usual, people caught him. So we were both talking, and I was saying that what Dr. Gill is saying here. And the same thing when I raised with Dr. Paturkar yesterday, Dr. Paturkar said the posts which are being now sanctioned are getting advertised. 50% is veterinarian and 50% is medical. So that's a good thing.
Thank you for reiterating that.
Subir, if I can just put up a small point.
Yeah.
Yeah, that's very good to hear what you said. Dr. Manju, thank you for a good talk. I almost repeat what Dr. Gill said. I was happy to know that you're conversing with ADG ICAR. But it would have been lovely seeing more of that input from the animal veterinary scientist sectors, either from the NAIR system or from the ICAR Research Institute, into your presentations. Because when you were talking about, you mainly took the MAFSU's Nagpur Veterinary College. So maybe in the time to come, you might look forward for that. But Dr. Gill is very aptly, he said, unless we shake hand, and you also said so. Thank you so much.
Sure. Maybe, I'm sorry, I just presented that small piece because of paucity of time. But the Anthrax project is being done with Odisha Agriculture University. We have also made RMRC Bhubaneswar. I didn't show my future plans. We are placing RMRC Bhubaneswar as a One Health hub for the bacterial zoonotic infections. in close collaboration with the local veterinary universities. So we are doing that. Even in the Northeast, Dr. Siraj Khan is here with me from RMRC Dibrugarh. He's closely collaborating with the veterinary universities and colleges there. So I think these are the people who actually are minds of knowledge, and they are the one who give us the veterinary side of the research, the universities. And ICR being a very large body, I always talk to Dr. Ashok Kumar, sir, find me a good partner in such and such place, even in Kerala or even in Gujarat. So he will say, okay, let me find you a good veterinary partner. So when he gives me, it is not restricted to only ICR institutes. We also expand to veterinary universities. We work closely with Tamil Nadu University. NI Chennai has worked very closely with them. Maybe in some other time, I can show you on a map that we try to, speak the same language and have everybody on board with us. Whoever in that particular geography can be together as a partner. But I take your point. We need to expand our horizon to other partners, even animal husbandry or the animal university.
Biotechnology, animal biotechnology also. No, thank you. Thank you very much, madam. It was really, don't feel that you should, when you go back, you should feel you're very important. And people caught and demanded a lot of things from you. Don't think that they were trying to push you. But it's so nice of you to be here. It's really a very wonderful interaction. Thank you so much, madam.
Same here. Pleasure is totally mine. I'm very happy I joined this. And
thank you, Dr. Manju. I have a question. I think it was very interesting that and informative that you have given an overview of zoonotic infection and how ICMR has contributed in surveillance, development of diagnostic assays, and combating these zoonotic infections. You talk much about bacterial and viral diseases, but what about protozoal diseases? Because they are an important class of organisms, and you have not touched these infections. So I saw a couple of parasitic diseases in your list, but can you just shed a light on it?
Thank you for touching a raw nerve. And in fact, I floated, okay, it's a failed attempt, but some other group is also working on it. So I tried to float a task force on soil transmitted helminths, because that becomes a very major, especially for the poorer communities, it's a major burden, and it's a major contributor to anemia and malnutrition in India. So NI Chennai has done some work. They are doing a deworm 3 kind of a project. I understand that's a gap area. But another group in ICMR is working on foodborne pathogens, and sporadically we have funded some extramural research on cysticercosis and echinococcus. These things are happening, but okay, that reminds me, yes, it's a wake-up call for me as well. We need to do, it's happening in a foodborne pathogen segment in some other area, but yes, parasitic infections and protozoal infections are important to be dealt with. And we need to put more focus on. Thank you for reminding it, and this is my take-home message today.
Thank you, Dr. Manju.
Thank you very much, Dr. Rahi. I believe we are running quite a bit late, and Dr. Walker Gertz, who must have awakened early in the morning, has joined us. So welcome him to this program. If Dr. Dinakar Raj can wait, can we go for Walker Gertz first, Dr. Dinakar Raj? Because he was scheduled at 6:30, and we don't want to.
Fine, sir, fine, no problem. I can wait.
Walker, are you online?
Yes, I'm here.
Can we take you now? Is it okay for you?
Yeah, we can. Can you see me?
Yes, we can. A very good morning at Saskatoon.
Sorry, I'm just getting ready here. And thank you. So it might be easy if I just turn my camera off and share my screen. I think that would be.
We'll have a brief introduction. We'll have a brief introduction, Walker, by the time you can get ready, I think.
Okay, that sounds good. Thank you.
Abhijit?
Yes, sir. Okay. So I'm pleased to introduce our next speaker, Dr. Walker Gertz. He's the director and CEO at Vaccine and Infectious Disease Organization, VIDO, at Hanover Veterinary School. Just brief introduction about Dr. Volker Gratz. Dr. Volker Gratz received a DVM in 1994 from Hanover Veterinary School and PhD from the Federal Research Institute for Animal Health, Hanover Veterinary School, Germany in 1997. He did his postdoc in the area of vaccine discovery and mucosal immunology from Vaccine and Infectious Disease Organization, the University of Saskatchewan. And in 2002, Dr. Volker joined VIDO as a research scientist. Later, he was appointed Associate Director of Research in 2007 and became Director and CEO in 2019. Regarding his research interest in the area of neonatal vaccines for both humans and animals, mucosal immunology and vaccine delivery and formulations. Current research projects are focused on vaccine development for porcine reproductive and respiratory syndrome virus, adjuvant porcine immunology, and the use of pigs as a model for humans, human modulation and regulation of mucosal immune responses. So with this brief introduction, I invite Dr. Volker Gratz on stage. Thank you.
Well, good morning, everyone, or good afternoon, I guess. Just checking in. Can you see the slides and can you hear me okay?
Yes.
Yes, Volker.
Perfect. Thank you. I just wanted to start out and say thank you for the invitation and also congratulations on setting up this One Health network that that you're inaugurating today and launching, and all the exciting work that's going on there. I'm sure that Baljet early on, I missed his talk, was referring to our joint efforts a few years ago in establishing a One Health initiative. But what you are doing is truly what needs to be done, connecting the main centers in the country, bringing them all on the same page, having them working closely with each other, I think is really the future. And I congratulate you to that. That's very, very exciting for you. So as you heard in the introduction, I'm the director of VIDO, but VIDO is located in Canada and not in Hanover in Germany. So just making sure that that is clear. So I'm located in Saskatchewan at the same university that Baljet currently is the vice president research of. And just a few slides of introduction to VIDO. So VIDO stands for the Vaccine and Infectious Disease Organization. It's a 45-year-old research organization that originally was a spin-off from the local vet college. But to me, VIDO has embodied what One Health is all about, looking for the links between veterinary and human medicine, using animal models to human disease, and studying those diseases that jump from humans into animals or animals into humans. And so it's really, in my mind, a One Health center. And of course, One Health is a major focus of our research. We have about 150 staff members and operate some of the most advanced infrastructure in the world, including Canada's largest high containment laboratory. And I show you a picture of it in the next slide. You can see there is more than $225 million in biocontainment infrastructure. We now received a grant from the government, and which was matched then by the province and the local municipal government. And we're expanding our biocontainment infrastructure to not only upgrading now to level 4, but also building new facilities that enable us to house exotic species like bats, reptiles, insects, non-human primates, and so on. You can see we're located in Saskatchewan, and over the years, some commercialized a number of vaccines. These are all animal vaccines, but we're now reaching out more strongly into the human health area. And as I will talk about today, have now vaccines for SARS-CoV-2, for RSV, parainfluenza, and other diseases in humans that are about to start clinical development. So this is Canada's largest high containment laboratory. It's what we call the International Vaccine Center. And you can see this facility here essentially has 2 wings. On the left side is the animal wing. On the right side is the laboratory wing. This animal wing alone was built to house large animals. And you can see we can house anything from very small, so bats, as you can see in the bottom there, to bison. We can house over 1,000 pigs in this level 3 facility. It's actually what we call a level 3 egg. So it's the highest level, is even above the level 3 that one would normally use for diseases like this. On the right side then are the level 3 labs. They're all on the main floor here. We're now building an in-house GMP vaccine manufacturing facility for human and animal vaccines right up here in the top 2 levels, which will give us then in-house access to vaccines to quickly proceed to clinical trials and so on. This is a collaborative center, and I would encourage you and your centers in India to make use of this facility. This facility is open to all researchers around the world, and the model is really that you can either have us completely do the work for you, you can come and bring your own team, or it could be a hybrid where, for example, you bring your scientist, or your scientist comes and spends half a year in Canada and uses our animal care team to complete your studies. If you fly over it, it's roughly the size of a football field, so quite the facility. And as I said, we're now upgrading it even to level 4, the highest level of containment. Now, this is where currently our research sits, and you can see we have both research projects in human health as well in animal health. So truly, in my mind, what One Health is all about. We don't do very much on the environment side, we're more on the diseases. So both in humans and animals, but you can see there's a wide range from respiratory to enteric to diseases to STIs. And then on the animal side, of course, there is organized by species, a lot of viral and bacterial diseases of relevance. But we're also reaching out in diseases that are somewhat different. So here, for example, chronic wasting disease or prion disease, huge problem, remaining a huge problem in North America. VIDO was one of the first organizations in the world who had a vaccine candidate, and we were very excited. It was developed by Scott Napper and Philip Greville, two prominent researchers at VIDO. Unfortunately, the vaccine didn't protect at the level we wanted, and so these two are now working on a new vaccine, which hopefully holds better promise in the future. But when SARS-CoV-2, when COVID hit, VIDO was one of the first organizations in Canada to respond to this new disease, to this new challenge. We were the first in Canada to isolate the virus from the first Canadian case, and this was done in collaboration with colleagues in Toronto at the University of Toronto at the Sunnybrook Health Center, and the National Microbiology Lab, which is in Winnipeg, and which is our government facility to look at emerging diseases. Having the virus then isolated, we were able to provide it back to the government facilities and all diagnostic labs in the country. And this was done by Dr. Daryl Falzerano, one of our coronavirus researchers, who at the time worked with MERS. And so I want to point that out because I think that is so important in what you're doing in India right now by establishing this network and bringing the expertise together. You have the ability to then rapidly switch and change gears as a new disease comes. And so Daryl, in fact, was working on MERS coronavirus. He had various collaborators around the world. And when SARS-CoV-2 hit, it was not a big jump for him to switch over to this new disease. And Daryl since has been leading our program here. And much of the work that I'm going to show today is actually because of his work that he has been done over the last 2 years. He was then the first in Canada to establish an animal model of disease, and I'll come back later on to in my presentation again, pointing out, I think, the expertise that we as veterinary organizations bring to these kind of research and why we chose initially the ferret and then switched over to the hamster, as many others have done now in the world. And we're the first university in Canada who is now in clinical trials with a vaccine candidate, and I'll show you some of those results as well. We, over the last 2 years, engaged with more than 100 organizations from all around the world. They have come to us to test their vaccine, their antivirals, and their therapeutics, and evaluate them in our preclinical models. And so talking specifically about the COVID-19 vaccine, which I was asked to do today, and talk a little bit about what VIDO has done, I wanted to start out with this slide, and I'm sure you've all have seen these original papers, so we don't really need to go into great detail, but this was early on the question, which species are going to be susceptible to this disease? And I'm sure the same was true in India. I had almost daily phone calls from ranchers who would ask me, can I go and see my cattle? Can I go and see my pigs? What about my horses? What about my dogs? What about my cats? And what about my pet animals? And so this is early on studies that came out and predicted the susceptibility of these species based on the receptor, homology of the receptor, the ACE2, that allows the virus to attach to the cells. And so as we know, the spike protein binds to the ACE2 receptor on the cell surface. And depending on how well the binding occurs, how strong the binding is, and how well the fit is, the easier it is for the virus to get in. And so therefore the prediction was that those species would be most susceptible. And so of course there is then a congruence between the binding score, so how intensely it binds, and the homology analysis. But this is where I wanted to get to, and this is why I think One Health is so important. We then quickly, or researchers came quickly up with a list of species that showed or were predicted to be very highly, or even not so highly susceptible to the disease. And you can see there is some interesting jumps in here. It's not all as obvious as we thought. So for example, the white-tailed deer is highly susceptible to this disease because of this homology in the ACE2 receptor and others. And this is, I think, again, where One Health is so important for our human colleagues to see. It's not only about the humans, but it's also about looking at and knowing which models are best for humans early on to use when we battle a pandemic like we have been doing now. And so you can see the hamster, of course, being one model, but also cats that are susceptible, dogs that don't support a productive replication of the virus, and pigs and so on. And so then many organizations like VIDO did initial studies looking at agricultural species. We looked at the susceptibility of pigs, and so did others. Studies were done in cats and dogs and sheep and so on to determine if all these species were also susceptible to the disease or not. We then decided, as I mentioned, to proceed with the Ferret model. That was our first model to do. And we had that established in March, so 2 months into the pandemic. And we were then even able in March already to immunize ferrets with our vaccine and test if our vaccine candidate would provide protection against the infection. We later switched over to the hamster because the clinical disease in hamsters is a bit more severe, as you know, and most organizations around the world are now using the hamster model. But here is showing you just 2 graphs from a ferret, and you can see that we can isolate the virus early on after infection, both in the nasal wash, as well as to some extent also orally. We do see histology, pathology and histology in these animals. So the ferret overall is a decent model for this disease and to test any drugs or antivirals or vaccines, as we then did. Of course, there is many other models that are now being used, and you heard some of that earlier on today, and many of your researchers are using these models. And of course, for the non-human primates, it's very hard to do right now research on non-human primates, as these species are not even available anymore because of the demand for them at the moment. We just completed a study, we completed a study in January of this year, started it late last year, in looking at African greens and tested our vaccine in African green monkeys, and it worked really, really well and protected even against respiratory replication in the upper respiratory tract. As I mentioned early on, and again, this is where One Health is so important. This is where organizations like yours are so important in helping our policymakers to make their decisions. This is a human disease, it's a human problem, but it was important to understand where the reservoirs for this virus are and what the role of our domestic and livestock species is. And so you can see here just a little overview that I put together on the various species that early on research was done to determine whether they are susceptible to the disease or whether they're host. Now, as we all know, and this doesn't need much introduction, these days everybody is a vaccine expert, and we all understand how to now make a vaccine for coronaviruses. But we obviously, everyone is focusing at the moment on either the spike protein by itself or the whole virus in form of an inactivated vaccine. The spike protein either delivered as a subunit, or delivered via a viral vector, or as delivered via RNA or DNA. And so the whole idea, of course, there is that we want to block the attachment of the virus to the cell surface. And so you can see here viral particles that are trying to get into the cell. Now, this is mediated, as we all know, by the virus binding to these receptors on the cell surface. And it is this spike protein, as I showed earlier, that makes this binding, this attachment of the virus to the cell. From then on, the virus will get in, take over the cell host machinery, make lots and lots of copies of itself. And while it's doing this, introduces mutations, which then are giving rise to these variants of concerns. Now, of course, the approach is for us to make vaccines that induce antibodies that prevent the attachment of the virus to the cell surface, and those we call neutralizing antibodies, an important criteria of many of these vaccines. And on the other hand, of course, we want cytotoxic T cells that can destroy these infected cells as early as possible, and thereby also destroy all the viral copies, so that rather than dealing with a full-blown infection, the immune system tries to kill its own cells as rapidly as possible and get rid of the pathogen that way. Now, of course, this is all happening in the airways, and so these are the cells, the epithelial cells that have the receptor on the surface, and this is where the virus initially tries to attach, and from there it spreads to other organs then and so on. And so, as I mentioned, many of our vaccines are focused on either the spike protein, either delivered via DNA or RNA, or as subunit protein, or as viral vector. There's now also a few inactivated vaccines out. The Sinovac, for example, is an inactivated vaccine. And initially, there was talk about using live viruses as vaccines, attenuated vaccines. However, other than one technology, one product, that hasn't really gone any further than that. And of course, the idea is once we have these antibodies that block the attachment of the virus to the receptor, the virus will not be able to get into the cell, and therefore we are protected. Now, there's various stages in vaccine development. And so just for your information, in Canada right now, Medicago, a company out of Quebec supported by a Japanese investor, is leading the field right now. They're already in phase 3. Vito and others are in phase 2 trials now. And of course, we all know globally the many vaccines that are already authorized in doing this. And so our vaccine is what is called a protein subunit vaccine. And so it's based on the protein as one subunit, and we're using an adjuvant with it, which is an all-in-water emulsion adjuvant that was developed at the Vaccine Formulation Institute in Switzerland. VFI is an institute that was originally set up by the WHO, and its sole purpose is really provide vaccine manufacturers in low and middle income countries access to vaccine technologies such as adjuvants. And so this adjuvant was developed by VFI. It's essentially a generic makeup of the MF59 adjuvant, and is now commercially available by through CEPIC, a company out of France. And so they have made now millions of doses of GMP material that is available for not only this vaccine, but also for other vaccines. And so as you can see here, it's the antigen is an S1 subunit. We're expressing it in HEC293 cells. The master cell bank is currently developed by a company called Resilience. The phase 2 material is available and being used in these trials right now, and phase 3 material will be available by the end of 2021. Now, the other thing we're doing is right now is adjusting our antigen to the new variants of concerns. And as I will show you later on, we have already confidence or data suggesting that the vaccine is highly effective against the Delta variant, but we also want to make it effective against some of these other variants of concerns, as I showed you here. And so we're now optimizing the antigen to do this. The adjuvant, as I mentioned, is comparable to the MF59 adjuvant, so it gives both Th1 and Th2 responses, and through the global access strategy by CEPIC is available at doses less than $1 per dose. And so this is just showing you some data from our preclinical trials. In this case, it's hamsters here, 2 immunizations. And you can see in blue are the vaccinated animals, and we're looking at weight loss here after infection. So they're dropping a little bit in weight, but then recovering quickly compared to the control group that lose significant weight. In some cases, we even have to euthanize these animals. When we look at control of viral replication, so how much virus is available or can be found in tissues after infection, you can see in blue There is essentially no virus that you can find in any of the respiratory tissues here. Whereas in black, as you can see, the control group, there's lots of virus in the upper respiratory tract, but also in the lower respiratory tract. When we look at the antibody titers, both functional antibodies on the left side measured by ELISA, and you can see we're getting very good immune responses to the vaccine. And then looking at neutralizing antibodies, those that I just showed you before that are critical in preventing the attachment, you can see they're the same thing, that the vaccine induces very strong titers compared to the control group, and also gives a little bit of Th1, Th2 slides. I can see there is a confidential on these slides. This information is not confidential, so it's totally fine. We also see protection against some of the variants, and so just showing one here, the B117, essentially the same data here. So the vaccine protects against the clinical disease. It reduces viral shedding and viral presence in the organs, and it also reduces significantly the pathology as well as immunohistochemistry in these tissues. Now, we then took our vaccine into clinical trials, and today I'm only going to show you the data, the interim results from our phase 1 trial. And so there we now went ahead and had 3 doses, so 25, 50, and 100 micrograms. This was done at 2 centers in Canada, here in Saskatoon, and then also in Halifax and at Dalhousie University, the Canadian Centre for Vaccinology, who are really the leading group in the country to run these clinical trials. And so there we found essentially that our vaccine was safe. There was no adverse reactions to it. The most common reported reaction was common headaches, but that was also even reported in our placebo control group. So you can see this is just individuals responding to the fact that there's an injection and that they have to go to the site and so on. Out of the 12 participants per group, so this is just showing you multi-group groups here, and we're still blinded technically, so we haven't unveiled the identity of these individuals, but we had 8 that were vaccinated in this group and 4 controls that received the placebo control. And you can see that 8 individuals in fact mounted high antibody titers that are comparable to the Moderna or the Pfizer vaccines. 8 had also neutralizing antibodies, and the T-cell responses are ongoing. So this is just showing you then the data from these trials, and you can see that there is per group in the various dose groups, but also in the various age groups, it is per group 8 individuals that are mounting an immune response, in this case neutralizing antibodies, both at the low and the high dose, and also in the older age group. And the same is true for functional antibodies, both in the low dose and the high dose, and also in the older age group. So we're seeing that our vaccine induces, in fact, very good immune responses. I'm missing a slide here that also looks at protection against the Delta virus in the animal model. And as I said before, we're seeing very good protection against the Delta variant with our vaccine as well. So this is where we are. In my mind, this is a prime example of what you're trying to accomplish in India, but you're doing it much better than we have done in Canada. This is, in my mind, how Vito was able to use our veterinary expertise to develop a vaccine for humans, which is now in clinical trials, the first time in our organization's history. But to me, that is what One Health is all about. Having the experts with the best particular expertise, whether it's an animal virus or a human virus, it doesn't really matter. Being able to rapidly switch to a new disease, rapidly develop a new program, and then develop a vaccine that one day can be used in humans. And so this is where we're seeing now Vito becoming Canada's Centre for Pandemic Research. The government has provided us funding now to, as I mentioned, upgrade our facility to the highest level. We have now in-house GMP vaccine manufacturing that is becoming available next year. And we're building this new animal facility that will allow our researchers to work with a wide range of species, from non-human primates to bats to insects to reptiles, and then of course all other species in between. And that will allow Vito to be able to rapidly respond to any new disease. And this time we were slower than the big companies because we had to outsource much of the vaccine manufacturing. In the future, that will be all done in-house, and we will be able to shorten our development time by another 6 months. And so we would have been able to start our clinical trials 6 months into the new disease. And so this is really, I think, where what you're doing in India right now is extremely beneficial, not only for your country, but for the world, convincing our human colleagues that there is real benefit, and the policy and decision makers, and that there is real benefit in having organizations that are operating in the One Health realm and that are able to rapidly respond to any new disease, whether it's a human or animal disease. And so, of course, I didn't do any of this work. This was all researchers here at VIDO. And you can see there is a large team that put countless hours into working not only on our vaccine, but also helping these 100 companies and users that came during the pandemic. And then, as you can see, our international partners, and I didn't talk about the Institut Pasteur Dakar. We're setting up now trials in Africa as well to make this vaccine available to the African continent as well. With that, thank you very much for your time, and I'm looking forward to answer any questions that you might have. Thank you so much.
Thank you, Volker. Maybe I'll start off. Thank you for having joined us, first of all, very early in the morning, I guess 6:30 a.m. at Saskatoon.
Oh, it's all right, yeah.
It's nice to
I have
see
young
you.
children, we're up at this time.
It's nice to see you again. I have a few questions. Do you ever work with the Food Inspection Agency related to foodborne diseases, and what sort of activities do you have at VIDO?
Yeah, so we in fact have an official MOU with the Canadian Food Inspection Agency in place. VIDO is search capacity to both the Public Health Agency as well as CFIA for any new outbreaks. And we have various collaborations with them at the moment, including, for example, African swine fever. So VIDO is one of the few organizations in the world and the only one in Canada that is allowed to work with African swine fever. It's a foreign animal disease here, and so under Canadian law, only government facilities are allowed to work with it. We have received permission or the exemptions to this and are now able to work on a vaccine for African swine fever in collaboration with our colleagues at CFIA.
A couple of other questions related to COVID. Your vaccine that you're making, how many doses do you need, and what would be the cost in comparison to the other vaccines?
2 doses. Yeah, so everything is set up for 2 doses at the moment. And the cost is, we're trying to bring it down to a few dollars per dose. The adjuvant is less than $1 per dose. And we're hoping that our antigen will be also less than $1 a dose.
And in your animal experiments, have you ever looked at the longevity of response, both the antibody and T cells, and how would that correlate with, I know the exact correlates of protection in humans are not known. How would that correlate with the humans?
Yeah, so we're doing these trials right now. We have long-term studies going on where we're looking at both duration of immunity after vaccination, but also after infection, after challenge. And so for the infection, which we started a bit earlier than our vaccination, we're out now a year. So essentially looking at animals that a year ago were infected and now are being reinfected to see if they're still protected or susceptible. And so as everybody else reports, protection is waning. And at a year, you can see now that even after natural infection, these animals are becoming, again, more susceptible to infection. So the duration of immunity is not very long. For our vaccine, we're out now half a year, and there we're still seeing good responses, but that's how far we have gone so far. These trials are ongoing.
So just quickly, when you say 1 year out, is that the same virus, no mutations? It's the same virus you're talking about.
There we used a homologous challenge, but we also now looking at, initial infection with the Wuhan strain and then a follow-up challenge with any of the other variants, whether it's the Delta now or one of the early ones, the Beta ones, for example. And you see differences there in terms of how well they respond. And so researchers Scott Napper and a few others at Vito are looking now at specific epitope mapping to see the differences in the response as we're using the different variants.
Thanks, Walker. I'll let others ask questions.
Yeah, Dr. Hegde, can I ask one question simply?
Yes, please.
Yeah. Good morning, Volker. Yeah.
Good morning.
I was also in Theodor's Arslike Hoxule with Volker Monig, then with this Irene Wilke. So I just want to ask you one thing, because in India, we are also experiencing the African swine fever, recently entered in India, northeastern region. Yeah. I am from the northeastern part of India. So here, this is really a very serious problem. And in One Health also, this is one of the study component for surveillance, this African swine fever in India. But presently, we also got fund for developing diagnostic and vaccine. I just ask you, can you give us some expertise guidance, what we are doing so that I can contact you in near future, not today?
Sure, happy to work with you together, and you might be happy to hear that the lead researcher for our African swine fever project is Suresh Tiku, who some of you I'm sure know, and so he's the lead there, and so you can contact him directly, or you can contact me, and I'm happy to pass it on to him. Glad to see the Hanover picture behind you there.
yeah. Thank you, sir. Thank you. Okay, sir.
So Volker Mönig, the director of the institute, was one of my two supervisors for my PhD.
Oh, hi, Gertz. Very good talk. And I would like to say the hamster model, how does it behave? I mean, if you do not, the controls where you just challenge with the virus, what happens to the lung condition? Does it recover by itself, or the animal succumbs to it?
No, so it really depends on the dose that you're using. Hamsters are getting sick, and so they're in some cases, if you give a high dose, they clinically become very ill, and we had a few animals that even died from the infection. They all recover after time. So they support viral replication in the upper and lower respiratory tract. You find the virus in various areas of the lung. You do find histological alterations, pathology in the lungs, and so on. It's not a great model, to be honest. It's not a great model. As you know, there is not many good models, and even the non-human primates are showing very mild disease. There is no real stringent model for this disease available, but the hamster is probably the easiest in that it shows good pathology, good clinical disease, and at the same time, is easy to work with. Like we must have done, I don't know, up to 100 clinical or preclinical trials over the last year, and you can't do this with non-human primates. You have to use a model that is concrete.
How does it match with the ACE2 overexpressing mice models, transgenic mice models?
Yeah, that's a possibility too. I believe that the disease you're seeing in hamsters is more severe than what you're seeing in the ACE2 mice. And again, we started our research already at a time when the ACE2 mice were not even available. So I think the hamster has some advantages over the ACE2
it's
mice.
Okay. I think most of the Indian vaccines are developed using hamster, because I had an additional charge of that institution for 6 months when these vaccines were all tested there. So hamster is a good model. That's not a really big issue. And only thing is that in human, as you see that the same dose of virus, some human will show very aggressive lung condition, and some of them will not. Do you see that in hamster with the same dose?
Yeah, we haven't looked at it, but what we're looking at using the Ferret model, we're looking at the long haul syndrome that we see. So that's part of what you're referring to, and so we do see that in some of these animals as well. And we're also looking at older animals, and in fact, we're seeing that the older animals are more susceptible, like we see in humans, and are more likely to switch to the long haul syndrome.
Okay, thank you. Great. Thanks for coming and joining with us.
Thanks for inviting me.
Dr. Hegde, could I ask a question, please?
Please, please.
Yeah, thank you, Volker, for a very enlightening and a very interesting talk. I'm Arnab Sen. I've just got one quick question. That is, since the spike protein is heavily glycosylated, do you feel that alternate receptors like C-type lectin receptors, then mannose-rich protein receptors, or neuropilin-1 could emerge as alternate receptors for COVID-19 apart from the ACE2?
It's possible. The reason why we're going with hex cells is because the protein is so heavily glycosylated. And I think it's critical for vaccine development to ensure that we have the proper antigen there. Whether the virus in the long term will use other receptors to get into the cells or not, I think it's possible, especially with coronaviruses as they mutate so rapidly. But the truth is, I'm not the molecular virologist who can answer this. So that's a question for some of my colleagues here.
Thank you.
But good question for sure.
Are there any other questions?
Dr. Hegde, can I ask a question?
Please, please.
Dr. Volker, I come from the medical field. I'm Dr. Nagamani from Gandhi Medical College. And we are seeing a lot of breakthrough infections, repeated infections in people who have recovered, as well as people who have also received vaccines. So how do we explain that?
Well, so like I think what we said earlier, for coronaviruses, immunity usually doesn't last very long, right? So that was one of the concerns that was brought up very early. And so depending on when these original infections occurred, I think within maybe 7 to 8 months, you might become susceptible to infection again. The data is out there and it's not fully known yet. What we know is that your T-cell responses are very long lasting. And so eventually after a second infection, you will be able to clear the infection and use the memory that you have. For our vaccines, I think it's very similar. The immunity might be a little bit stronger than what you see after natural infection. And so these breakthroughs often are linked to other comorbidities. So for people that have chronic diseases and so on, and often occur in those more often. So for vaccines, I would predict on what is available right now that we probably need to boost every 2 years the latest. You get good T-cell responses, but your antibodies are lasting much shorter. You might be susceptible to reinfection again, but will not see severe clinical disease unless you're suffering from another underlying comorbidity.
Yeah, actually, we have seen people getting infected in the first wave and the second wave as well, and young and healthy people.
And was that infection after like a reinfection? So part of the natural infection is that the duration of the immunity, like the magnitude of the immune response, seems to be correlated with severity of disease. So in those individuals that only had mild infection initially in the first infection, they don't make very strong immune responses and then become susceptible again to reinfection. In contrast to individuals who really battled the disease in the first one, have very severe disease, they typically mount a stronger immune response.
Yeah, thank you.
I think we'll end it there. Walker, thank you very much, and come back to Hyderabad. I can't remember when it was last time you came, but do come back to Hyderabad.
It was a few years ago, maybe 5 or 6 years ago or something like that.
More than that.
We'll do as soon as, more than that maybe, yes. As soon as the pandemic allows us to travel again, we'll be there.
Please visit our institute.
Again, thank you. Yeah. Thank you very much for the invitation and congratulations on setting up this impressive network that you're doing right now.
Thank you, Walker. I think we can move to the next presentation. Abhijit?
Yeah. Hello. Yeah. Thank you, Doctor. Thank you, Dr. Volker. Let's move on to the next speaker, the last speaker of this today's mini symposium, Dr. Dinakar Raj. Dr. Dinakar Raj, brief introduction about Dr. Dinakar Raj. He did undergraduate studies at Madras Veterinary College from Tamil Nadu Agricultural University in 1986. He was a gold medalist. In fact, he received 4 gold medals during his undergraduate studies. Subsequently, he completed his master's studies in biotechnology at IBRI in 1989. Then he moved to UK for his doctoral studies on a common health fellowship program in 1997. He did 2 postdocs, first at the University of Nebraska and later at Ferret Institute, UK. In between, he joined the Tamil Nadu Veterinary and Animal Sciences University as an associate professor and subsequently professor. He is also a project director of the Translation Research Platform for Veterinary Biological, a collaborative initiative between the Department of Biotechnology and Tanuvas. Currently, he is a director at Center for Animal Health Studies and at Veterinary Innovation Foundation at Tanuvas. He has developed several diagnostic tests for animal and poultry diseases, such as, to name a few, Leptospirosis, blue-tongue disease, and egg drop syndrome. He has published more than 150 articles in international peer-reviewed journals and several books. He holds several national and international patents. He is also a recipient of several awards. To name a few, Dr. F.M. Baljet Award of the Indian Society for Veterinary Immunology and Biotechnology in 2006, a National Bioscience Award for Career Development, one of the highest Indian science awards in 2007, Tata Innovation Fellowship of DBT in 2012. With this, I request Dr. Dinakar Raj to first talk. So the title of the talk is One Health Approach Combating Challenges of Zoonotic Disease.
Yeah, thank you, and I hope I'm audible and my slides are visible.
Yes, yes.
Yeah.
And thank you for waiting.
Yeah, fine. No, the guests are always priority. So today I'll be, thanks for the opportunity and salutations and greetings to this online audience. So we just heard a talk about zoonotic diseases and One Health approach from the medical fraternity. So probably I would be trying to highlight some of the aspects and the work that we have done from the animal or the veterinary scientist part. So I'll be briefly talking a bit about One Health that most of us already know, and then we'll be highlighting some of the work that we have done on both the diagnostic as well as the surveillance aspects of few zoonotic diseases. So we all know that there are a lot of huge health threats, mostly driven by globalization, population growth, and economic growth, food security, and changing habitats. And just a few numbers for you, the numbers game. We know that humans are infected with 1,407 pathogens. Of these, about 61% are animals and 40% are viruses. And 75% of emerging diseases have animal origin. 5 new human diseases appear every year. Of these, 3 are from human origin. 80% of bioterrorism agents are zoonotic, and more than 31 bacterial genera cause foodborne illnesses. And again, we all know, just to recap, that disease is caused by the interaction between the pathogen, host, and the environment. That's the disease pyramid, as we call. But when we go to the pathogen pyramid, so we know that there are different levels of interaction between a pathogen and a host, be it human or animal. So initially, the pathogen may get exposed to the host, some of which will cause infection in the host. Then the pathogen gains the ability to start transmitting between the host, and then finally it has the potential to have a epidemic spread, or it again stays in an endemic state. So it's not necessary that the pathogen has to move from level 1, 2, 3, 4. It can directly move from 1 to 3 or 1 to 4. So the classical example, as we all heard, is from COVID-19. So we know it came from bat. We don't know the intermediate host. Then it had the ability to infect humans, started transmitting very well and caused a pandemic. So if you really recap that to the COVID in animals, probably it was a reverse zoonosis. So the virus is been exposed to a lot of animals, some of which had got infected. Probably the transmission is very low, but it's very likely, although not what we would expect, that the pathogen may start transmitting between these animals, and then it is probably likely to also maintain itself in an endemic state or cause some kind of epidemics in future also, which is potentially possible. And we all know about One Health. Again, just to recap, it's just working together, forgetting our barriers. We work in a interdisciplinary or a multidisciplinary or a transdisciplinary mode. So transdisciplinary is the highest form where there are no divisions, there are no disciplines. Basically, everybody works under a single roof. So it is totally a mindset game. So I would like to, equate it to something like the IPL cricket, franchisee cricket, where, the Australian captain comes and plays under the Indian wicketkeeper. And if the Indian wicketkeeper asks him to run from mid-on to deep mid-on, so he has to run, he has to obey. He cannot say that I am the Australian captain and you cannot direct me to change the field. So this is the kind of a mindset that basically One Health requires, and this has been the most challenging part. So obviously, we have the expertise, we have the need, we understand the need to collaborate and so on. But how basically we implement that is going to, decide whether we are going to be successful. So it is basically a, interdisciplinary strategy where you address health from multidimensional angle so that we get a holistic outcome. So we know it is not a discipline, it is only a approach or a mindset. So again, because of One Health, we know that there is going to be efficient alignment of all the few resources we have, and we can not only detect but also recommend and implement appropriate therapeutic and other protective intervention that is most important rather than just understand. So this is again a classical example in animals. So we talk about coccidiosis. So when we kind of diagnose coccidiosis, the kind of intervention must come from the production angle, not only from the disease angle, because we know that the kind of management system in the poultry house only creates adequate and conducive environment for coccidiosis infections such as litter and cleaning litter and so on. So although we diagnose disease, the remedy is from the production angle. So if you kind of extrapolate this to between disciplines, that is what One Health is all about. And we know we have challenges. We understand that we need a policy framework. And at present, we have institutions that are having expertise in particular sectors, and they have the funding also is very sector specific. And mostly the emphasis is only on that particular expertise rather than a broader vision. And these all has to change if we have to go, create this One Health implications. So we also know that there is a public health emergency of international concerns. You can see here during the last 20 years, we have had one kind of an emergency every third year. So this public health emergency again is an extraordinary event which does not affect only the public health of a particular state or a country, but has an international effect and impact. And so obviously, the need for One Health is understood very well under the present pandemic times. And we know zoonotic diseases are diseases which occur between animals and man. And we have a whole set of viral and bacterial and rickettsial and protozoal, helminthic, fungal, and ectoparasites. So these diseases, as I said earlier, may be endemic, may be like leptospirosis, or may have an epidemic proportion like Japanese encephalitis and so on. So here I've just highlighted certain diseases that I'll be presenting some information that has been done in our institution. So the rabies, brucellosis, tuberculosis, and leptospirosis. So leptospirosis will start that it's a classical example for a One Health approach, because you see the life cycle of the organism. You have certain asymptomatic carriers in rodents. It can also affect wild animals. It is also present in the environment. And then obviously it can affect the human. So this pathogenesis is a classical and an ideal example. And if you want to control leptospirosis, obviously it could only be possible through a One Health approach. So leptospirosis, we all know, it is a spirochete which has got spiral organism, and there are a lot of pathogenic organisms. Some are intermediate, some are non-pathogenic. There are 25 serogroups and more than 250 serovars. And if you see the pathogenesis of the disease, you have an acute stage during the first week, and then you have a convalescent state, and then you have a prolonged chronic infection, which is mostly leptospiruria, where you have the leptospires in the urine. The initial stages, you have that in the blood, where the person is acutely infected and sick. And you also look at antibody titers during the early part of the infection. And during the later stages, you look more at the organisms in the urine. And the diagnosis is based on history, the duration of infection, as well as the serovar that is infecting. And Tanvas has had a long legacy of leptospira diagnosis, probably one of the first labs in India to start offering the microscopic agglutination test as a means of diagnosis for both human as well as animal samples. So in our lab, we maintain 12 serovars that are highlighted here, and give some of the data during the earlier part, like 2017 and 20, where, as I said earlier, we do MAT. These are the positive human samples and the positive animal samples. And we have used other tests other than MAT, and we found that the positivities are very, very low. And these are the positivity in different agroclimatic zones, and we have very high positivity in and around the Chennai area. And during the more recent times, during the last 2 years, during 19 and 20, you can see that there has been a tremendous decline in the number of positive samples in human. So you see the positivity is hardly about 2.1%, whereas in animals, we have a slightly higher positivity of 16.1%. So even if you had classified the positivity across risk group and general public, the risk group do not get infected. So this has been a striking and a strange observation. Even during the massive floods in Chennai, there was no single case or outbreak of leptospira in Chennai, unlike what we normally see during the monsoons in Mumbai. So probably we felt that because of the huge flood, all the water got washed away into the sea. Probably the organisms also could not survive in that turbulent movement of water. But this is what we are seeing during the last few years, that the human infections have come down dramatically as compared to the animal infection. So if you see the common serogroups in animals, you can see that Australis and autumnalis are the most prevalent. And compared to humans, you again see Australis autumnalis that is most prevalent. So this again shows you that probably the origin of the infection could be either way from human to dogs or from dogs to human. So moving on to the other zoonotic disease, bovine tuberculosis, where we have a DBT funded project, and we have looked at the prevalence data of bovine TB using two types of assays. One is a single intradermal test, which uses only the PPD bovine. purified test is a comparative test where we use PPD from bovine as well as PPD from avian to rule out the exposure to environmental mycobacteria, which will cause reactivity to avian, which is kind of detected. The skin thickness is detected from the PPD skin thickness, and we arrive at a diagnostic method. So if you see here, there are two assays. Of course, we also do IGRA and some serology, but mostly limited to wildlife. But our data on single intradermal and double intradermal or a comparative intradermal test have given totally diverging prevalence estimates. So as I said earlier, here we inoculate PPD bovine and PPD avian, and then we measure the skin thickness before inoculation and 3 days after inoculation, and we subtract the skin thickness from the skin thickness at day 0, and then we also subtract the skin thickness from avian from PPD bovine. And if the difference in thickness is more than 4 mm, then we consider that animal is positive, which is what the OAE recommends. So we have got different kind of buckets of reactors. This is a classical example where the skin thickness of PPD bovine minus PPD avian is more than 4 mm. So this B1 and A1 is before inoculation, B2, A2 is after inoculation. Then delta B is PPD bovine after and minus before, and delta A is PPD avian after and before. And if delta B minus delta A is more than 4 mm, it is considered as positive. This is a classical positive case. But we also find in certain animals that PPD bovine is positive more than 4 mm. But because the thickness of PPD avian is also high, so that B minus A turns negative, and we would classify this animal as negative in a comparative test, but positive in a single intradermal test. So we also have cases where bovine reactivity is less than 4 mm, which is negative, but avian reactivity is more than 4 mm, which is positive for avian, and this probably is masking the positivity of the PPD bovine. But as per the criteria, we would consider that as negative. So if you really see a kind of estimate of prevalence done at different places, about 827 animals, if you consider a single intradermal test, we would say that the prevalence is about 16%. And to environmental bacteria, it is much higher than this, it's about 24%. But if you say PPD B minus A as the criteria, the prevalence from 16% drops to only 2.5%. So again, there are cases where B is positive, A is positive, but B minus A also turn negative. So this is also about 9.9%. So these are various groups of animals, and how do we interpret this? Depends on what is your assay requirement. So here we see a very low prevalence totally taken together if you take B minus A. And in terms of different Gauchalas also, the prevalence is very low, contrary to what we would expect. And organized farm also, it is, organized farm, it is high, and smallholder farms, it is again very low. So we all know TB is a herd disease. And in a herd, if a couple of animals get infected, so in the years to come, you don't get rid of that infected animal, the whole herd tends to, or large proportion of the herd tends to become positive. So, but what was striking again is, being a chronic disease, the animals with more than 4 years had significantly higher positive rate than younger animals. And this is what we have. If you take PPD B alone, you may overestimate the disease. If you take PPD B minus A, you may underestimate the disease. So what is the solution? The solution depends on what is the aim of your diagnosis. If I want to diagnose a herd as positive or negative, then I might go for a test which has got higher specificity. That means the single double intradermal. If I want to do an animal as positive, then I use a test with higher sensitivity, and I use the PPD bovine itself. So this is a kind of a catch-22 situation where you have to be very clear about the the assay requirement, and what is the objective of testing. That is what is shown here. And more recently, we have been isolating bovine tuberculosis from animals, and this is some of the data that is published recently from India. So most of the mycobacteria that we see belong to oryges, and oryges is actually shown here. And this particular mycobacteria was first reported in a oryx, which is oryx gazelle in family Bovidae. And this organism has been shown to be a reverse zoonotic organism, meaning it comes from humans into animals. This has been clearly proved in a case in New Zealand, but it has also been shown in many other animals, as well as in lymphadenitis from a human. So this pathogen appears to be present both in human and animals. And this is a recent study by Duffy et al., where they have characterized 940 cultures of MTB, and they found 913 was Mycobacterium tuberculosis, and oryges was 0.7. And strikingly, they did not find any Mycobacterium bovis. So what normally we considered as zoonosis is from animals to human. If you find Mycobacterium bovis in human, then you can say that probably the organism came from animals. But what we have found, what they have found is there was no Mycobacterium bovis from human, which means that probably animals are not transmitting as we really make out to be. And in the study that we have done, we characterized isolate from cattle a couple of years back, and we found that as Mycobacterium oryges. And more recently, which is unpublished data, we have characterized 5 Mycobacterium, 4 isolated from cattle and 1 from deer. All the 5 turned out to be Mycobacterium oryges. So what we kind of predict is whether Mycobacterium oryges is probably coming from cattle into human, or probably moving from human to cattle. But some literature suggests that oryges originated much before Mycobacterium bovis, and probably bovis got adapted into exotic cattle and oryges got adapted into indigenous cattle. But more importantly, we are seeing more of oryges positive cases in the recent times. And earlier days, probably there was no mechanism to differentiate Mycobacterium bovis from oryges, and probably many oryges isolates were misclassified as Mycobacterium bovis. So moving on to the other disease, brucellosis. So again, here we have a kit that is made using monoclonal antibodies, and we also do the conventional test like Rose Bengal for animals and standard tube agglutination with human sera. And we have done some sera surveillance using all these kits. We have done 2 C. ELISA kits. One is our Brew Alert. The other one is a kit from a company called Swanover. And we also did STAT and RBPT. And our kit performs very well with 100% sensitivity and specificity for human samples, and about 99% sensitivity and 100% specificity for bovine samples. And this is the correlation of the PI values. We get a good R2 of 0.85 or 0.77 for human and bovine samples. And when we looked at seroprevalence data in bovine and human, we found that the bovine seropositivity is about 10.43, and the human seropositivity is much higher at about 17.43. But using alternate tests, the seropositivities are low. But this was a biased sample where we only sampled the people in the slaughterhouses. So this is the bovine sample. We find that organized farms do not have any positivity, but unorganized farm and slaughterhouse samples have higher positive rates. But again, indigenous breeds, they have very low positivity for brucellosis. But you find crossbred of Jersey and HF crosses showing high positivity of 58.8 from Jersey and 41.2 from HF crosses. And human samples, as I said, we only took slaughterhouse people and animal handlers, so positivity rates are very high. And more interestingly, all this pyrexia of unknown origin cases, which were negative for dengue, malaria, typhoid, scrub typhus, and leptospira, there were 10% positivity of that PUO cases for brucellosis. This again gives a clear indication that since we don't diagnose brucellosis in such PUO cases, we are missing about 10% of the samples. And interestingly, all this 10% or 9 samples out of 88 which were positive, they belong to animal handlers. So they are the most disproved population which are likely to get brucellosis. And we also have a NABL accredited facility for rabies diagnosis, both human and animals. And we do two kinds, this is NABL accreditation. We do 2 tests. One is a direct fluorescence antibody for antigen detection in the brain samples, which is shown here. This is a negative sample, and this is a positive sample of brain, and this is the virus grown in BHK21 cell culture. And for antibody, we do what is called the fluorescent antibody virus neutralization test. This test is required when anybody wants to take his dog out of the country. So the importing country requires that a certificate is given where the vaccinal antibodies are measured. And as we all know, the protective titer should be more than 0.5 IU. So unless you have a protective titer, the animal is not allowed to be taken along with the owner to the importing country. So this is some of the data we have done for the last 4 years. And you see, these are the dog samples. So we have DFAT in 2018, there was huge positivity, about 66 out of 77. And then during the last 2-3 years, the positivity rate for antigen has come down. But the serum antibody also we do, as I said, for export purposes or for looking at post-vaccinal seroconversion data. And we find that good positive rates are there in the serum. And we also offer this facility for human sample. So last 3-4 years, we have got 4 human samples of either conjunctival or corneal or brain impression sphere, of which 3 samples were found to be positive. So this is again a suspect case that is referred to us. So there is the reason for that high positivity in human sample, which means that rabies is still widely prevalent both in dogs as well as in human. And again, One Health mode only, this disease can be controlled. As the earlier speaker said, it is criminal to allow a person to die of rabies because it is a highly preventable disease. And in terms of prevention, there should be more active responses from both veterinarians and the medical field. So to sum up, we know that One Health, which is based on cross-sectoral collaboration and convergence, is very useful. Every one of us know, but that is not being implemented. So at least we should make a small start, and this consortia is definitely a good start. And even in that consortia, I think initially, basic information sharing or undertaking common activities with synergistic and synchronous technique or protocols to be followed, and sharing of resources and infrastructure may be a good beginning. And all this may work initially, at a interpersonal level, more than going at institutional and at ICR or ICMR levels. If individually we tend to collaborate, we get to know each other and start sharing information and resources, that I think would be a good start. And probably in the later days to come, the policy framework would also fortify and aid this kind of collaboration. So I will end with this slide. So we always think what I can do, and we try to do different things. You can see here, we are just individual petals. Person A does different thing, B does different thing, C does different thing, because we always feel this is what I can do. we never think that what needs to be done. If to solve a problem, A, B, C persons have to come together, then only we can flower. And I think this is a very good beginning. Kudos to all the people involved, especially DBT, Dr. Subir, Hegde, and others, Dr. Rawat, and so on. So we all should take this, bear this in mind, that we need to do this and we need to bury our differences and come together, just like the IPL franchisee, and hope CSK is going to win on Friday. Thank you.
Thank you, Dr. Dinkar Raj.
Yeah, thanks, Dr. Dinkar. It was so full of knowledge, and looks like without you, this consortium will be really.
Nobody is indispensable. Sir.
No, but you have vast knowledge, as others also have. But you see, you have really practically done a lot of things. So I see senior people like Dr. Gill or on hospital side. I would expect this from Dr. Pankaj, Dr. Nagmani, and also from Dr. Mavlang, and Rajnikant Saab is here, Shiraj is here, and all of our definitely veterinarian colleagues. So I'm really happy, Dinkar, for all of your talk. And most importantly, I thank all of them who are still here. I'll not name anyone, all senior, all middle, like I don't know where should I fall, and the juniors. Such a enthusiasm and excitement. It's a wonderful thing. And as Dr. Dinkar has said, a lot of important things. I think Dr. Gill also would like to add the advice. I don't know. He's turning on. And I thank, and importantly, before we forget, we must thank Dr. A.K. Rawat, who was instrumental. And although we thanked each other, but not Dr. A.K. Rawat yet, in bringing out this whole version of One Health with so many centers. So it's his goodwill also, which allowed all of us to gel well. Thank you very much to all of you, and also to Dr. Dinkar Raj.
Before we end the program, I would request Dr. Gill to speak a few words.
Thank you, Dr. Hegde and Dr. Subir. It is a very good initiation and a start, but we have a long way to go. There will be many hurdles. We have to mend our ways, have a midterm reviews and midterm changes. And I hope with all the seniors, Dr. Dinkar Raj and other peoples from medical side and veterinary sides, so we keep it them taking the advice. Just like I just give one example. Just we initiated the One Health project in 2011 with Baljet. So they have every year we keep on changing our track. So and final after 2 or 3 years we were on very strong footing. So in all the review meetings, we need the good advice from all the senior peoples, Dr. Rawat, Dr. R.K. Singh, and all other persons who have done very good work. I especially congratulate Dr. Subir for your hard work and making all the people together, and Dr. Rawat, who was main source or spirit from the backside and working over this. So I thanks all the persons for this being the part of this consortium. So for all help from the Gadwasu, our past experiences from One Health, we are all with you. Dr. Bedi is there, and for all sport we are there. So I wish a good success for this consortium.
Thank you, Dr. Gill. Now the senior most medical person, Dr. Nagmani. Dr. Nagmani, can you hear us? Any comments from your side? You're the senior most in medical sciences.
Yeah. I thank all of you. I really appreciate all the effort that you have put in. All the team from NIAB and all the other senior faculty members. Looking forward to a wonderful work. I hope that all of us will work together and come out with a good outcome.
Definitely.
Thank you for including all people from other institutions and then giving us opportunity to be a part of this One Health program.
Thank you, madam. And senior most from the Northeast, Dr. Burman. Dr. Burman, are you around?
Yeah. Sir, yes, sir. It is indeed a very good initiative, and really I congratulate all the team from the NIAB and DBT giving this opportunity. And I feel this is a platform where everybody should work as worker, not recognized as someone is very specialist, considered as a worker. So then this homogeneity will be maintained and this One Health platform will prosper nicely as we see. That is my the impression. Thank you, sir.
Dr. Hegde?
Dr. Rawat is there.
Dr. Rawat,
a couple of words, please.
Okay, thank you very much. Thank you very much. And actually, I feel that I will cherish those moments when we were preparing this project. And it is actually, I can say one thing, that this project is a hard work of Dr. Subir Majumdar and Dr. Hegde. This project, I think, during my entire tenure in DBT, I spent almost 26 years in DBT. And this is the project which was evaluated several times, not once, twice or thrice, several times by several committees. And sometimes I felt frustrated actually. But it was Subir and Dr. Hegde who took it up. And then ultimately this mega project has come up. It's a very difficult project. I can say one thing, that it will be actually that the journey had just now started now, you can say. And now we have to come together, we have to put our best foot forward and then go ahead. And I hope that if we have people like Subir, Dr. Hegde, Dr. Dinakar Raj, Dr. Gill, so I think that success will be there. Initially, this project is for 3 years, but I hope that based on the progress of this project, it will be further extended. And support from DBT, particularly by Dr. Nanolia, outstanding. I don't know whether he is there or not. He has done a lot of good work. And if we get support like this only, we'll certainly get success. So thank you very much and best of luck.
Thank you, sir. I think Lokesh is showing up. Lokesh, thank you. Bye.
Yeah.
So,
I thank all the speakers for taking time out and accepting our request in a very short time, notice time. So now I request Director NIB.
This reminds us that we should thank Bapaditya, Prasad and Abhijit.
I was about to do that.
For helping
I
us.
request Director NIB to formally give vote of thanks.
Acha, there is formal vote of thanks. Good.
Thanks, Abhijit. First of all, thank you all for staying this long and in the evening. Especially, I thank initially the Secretary Madam for inaugurating this and those people, Dr. Chattopadhyay, Dr. Parag Nigam, who spoke about the importance of different stakeholders and wildlife. I sincerely thank Dr. Baljet Singh for a philosophical silver lining to kickstart this project. Hopefully, we can keep deriving his advice and counsel throughout the course of this project. I would like to thank Dr. Manju Rahi for accepting our invitation on a short notice, talking to us and also candidly presenting her views on both sides of the aisle. I would also like to thank Walker Gerds, an old friend of mine from Vido, who woke up early in the morning to deliver his talk on One Health, especially on COVID. Hopefully we can get Walker over here in Hyderabad or any other center during one of these meetings. And I thank Dr. Dinakar Raj for presenting veterinary side of the view on One Health and how we can move forward. I thank each and every one of the consortium who have responded to our calls whenever we, frantically invited them to the meeting. Sometimes it was on a very, very short notice, and also providing information to put together this project and the consortium. And I thank the ICT of NIAB, other people of NIAB who have helped us with various things. And of course, thanks to Dr. Prasad Rao, Papaditya De, and Abhijit Deshmukh for conducting this symposium. Thank you one and all. Hopefully we'll meet physically, all of us will meet physically on 20th and 21st. Thank you. Subir sir, you have anything to say?
Thank you very much. Thanks for waiting for a long time. And from top to bottom, everyone we thank and we request that we will join and really have a good interactive session, and they should participate, and which they are doing. And I'm grateful to all of you, Thank you so much.
Thank you and good night.
Thank you. Thank you.
Good evening.
Thank you.
Thank you.
Thank you. Good night.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you.
Thank you. Good night, everyone.
Thank you.
Thank you, sir.
Thanks. Thank you. ठीक हो?
Yes, sir.
Very good. Very good. बड़े दिनों में नजर आया हो. Thank you, Vikram.
Thank you, sir.
नरनोलिया ठीक चल रहा है?
Yes, sir. ठीक चल रहा है.
Good.
आपका इंस्टीट्यूट आओ यार एक बार.
ये अभी आ जाएगा 20-21 को, उसको लिखते हैं ना. We'll write him to come at 20-21.
Yeah.
बड़ोगलाई साहब, नमस्कार. डॉक्टर जितेन, नमस्कार. तो नरनोलिया एक ट्राई करो 20-21 को आने का.
जी सर, करते हैं ट्राई सर.
अभी चिट्ठी लिखेंगे आपको.
हाँ.
वन हेल्थ का प्रोग्राम वो करने के लिए मैडम को बता दिया आज हमने 20-21 को भी है.
हाँ.
उसके हिसाब से कर देंगे.
सर कोशिश करते हैं 20-21 तो एक्चुअली 22 को तो वो कैनाइन की है मीटिंग.
अच्छा. 20-21 आ जाओ ना. 21 रात को चले जाना. क्या है, शाम को चले जाना.
हाँ, यही करना होगा सर.
और क्या
सर, ये एमओयू वाला देख लीजिएगा सर.
वो किसके साथ वाला?
हाँ, वो सबका फॉलो अप करना है.
साथ है. हाँ.
यू नहीं ए. एमओ ए है ना.
एमओए सर.
हाँ, मैं वही सोच रहा नया एमओए.
नहीं
एमओए करेंगे. नहीं तो देखेंगे वो वाइल्ड लाइफ के भी उनको ले आए थे ना डॉक्टर पराग को.
अच्छा.
उनको हमने बहुत बातें कर. वो रियल वाइल्ड लाइफ के लोग हैं. अगर यहाँ प्रॉब्लम होगा तो फिर वहां देखना पड़ेगा. डीबीटी के थ्रू से, चेयरमैन के थ्रू से कर लेंगे. मैडम के रहते करेंगे फिर वो.
हाँ सर, यही अभी कर ले तो
अभी कर लेते हैं. मैडम को समझ रहा है ये चीज.
हाँ.
ये हरजीत ठीक है? हरजीत कहाँ है?
हरजीत शायद ऑन करके गया है.
नहीं, वही हिल रहा है. कुछ लोगों ने इसे ऑन किया है. चलो ठीक है लोकेश.
ओके सर. बाय सर. गुड नाइट सर. गुड नाइट.
तुम्हें कैसा लगा लोकेश ये प्रोग्राम? अच्छा था?
अच्छा था सर, अच्छा था. बीच वाली टॉक मेरी मिस हो गई थी, लेकिन स्टार्टिंग था और एंडिंग वाला अच्छा था सर.
नहीं, मैडम वाला ठीक था ना. मैडम
का वो अच्छा रहा. हाँ, मैम वाला अच्छा रहा.
मैडम भी खुश थी. बहुत अच्छा रहा.
हाँ, अच्छा रहा सर. काफी अच्छा रहा सर.
गुड. थैंक यू.
कांग्रेचुलेशन सर.
थैंक यू. कांग्रेचुलेशन टू यू. तुम मालिक हो. थैंक यू.
ओके सर. बाय सर.
Take care. Bye.
Good night. Good night.